abnormal muscle tone in the neck, which is causing the head to twist and turn to the opposite side. Maybe congenital or acquired, it can occur at any age, but usually presents within the few weeks after birth. Usually it is maybe due to birth trauma. Other rare causes are acute myositis, brainstem tumors, atlantoaxial subluxation, and infectious causes. It is usually physiotherapy is necessary, but rarely surgical resection or division of the involved fascia or involved muscle is rarely indicated. Then next will be the cystic hygroma. It is due to the multiloculated cystic splits, which are lined by endothelial cells occurring as a result of some lymphatic malformation. Usually due to malformation in the lymphatic jugular sacs in the posterior neck regions. The other common sites are the axillary, mediastinal, inguinal, and retroperitoneal organs. The cystic hygroma or the lymphovascular malformations can occur anywhere from the neck up to the retroperitoneal region, but the most common site be the posterior neck region, followed by axillary, mediastinal, and inguinal. While 50% of the cystic lesions are present at birth, during birth it may cause significant risk to the airway, and it is also associated with other chromosomal abnormalities. So the prenatal ultrasound or prenatal MRI allows the careful coordination of the size of the lesions, which allow in surgical intervention or exit procedure at the time of the delivery. The most common complications being the infection and the hemorrhage. Usually we can inject sclerosing agents such as bleomycin, doxycycline, or OK432. But the most preferred treatment will be the complete surgical excision. But it will be very difficult since it does not follow the plane. It is usually infiltrated into the muscles and most commonly compromising the airway. So main preferred treatment is the surgical excision. But before surgical excision, we can inject sclerosing agent to shrink the size of the tumor and to it become fibrous. And the next will be the midline lesions, which is the thyroglossal duct cyst. It is a midline lesion which originates at the base of the tongue at the foramen cecum, and usually it descends through the central portion of the hyoid bone. So embryologically it descends in between the two parts of the hyoid bone while the formation. So it is absolutely necessary to remove the middle part of the hyoid bone during excision of the thyroglossal cyst. Usually it found just below the hyoid bone. Also it may be infrahyoid or suprahyoid, usually infrahyoid region. Yet it is a thyroid diverticulum which develops as a median endodermal thickening at the foramen cecum in the embryonic stage, and then it descends in the neck, but it remains attached to the base of the tongue by the thyroglossal duct. As it descends to its normal pretracheal position, the ventral cartilage of the second and third branchial arches, which form the hyoid bone, hence the intimate anatomic relationship of the thyroglossal remnant with the central portion. So the clinical features being most common as it presents the midline neck swelling, but usually it may be to the slightly left side of the midline. It is usually painless and cystic and smooth. It moves with deglutition and usually differentiate from the thyroid lesions by it moves upwards with the protrusion of the tongue. They may become infected and present with pain, redness, and infection and tenderness. This is the swelling, and it moves by deglutition. So it is the infected thyroglossal cyst. So investigations most common being the ultrasound, and preoperative thyroid scintigraphy is rarely required if in ultrasound when there is no thyroid gland is present, or if it is only the functioning thyroid tissue. So treatment will be, although it is generally benign and mostly asymptomatic, it is to be removed for the following process to eliminate the chance of infection and the abscess formation, and for cosmetic reasons. And in rare cases, there is a risk of malignancy. But when malignancy develops, the most common being the papillary type, and more than 80%. So the treatment is the complete excision of the thyroglossal cyst along with the middle third of the thyroid bone, and it should be traced up to the base of the tongue and ligated and excised completely to prevent the recurrence. It is a cyst-trunk procedure. The next topic will be the congenital diaphragmatic hernia. The various types of congenital diaphragmatic hernia are posterolateral in location, which is called Bugdalac hernia. This is the most common, and also it is the left side is more common than the right. On the anteromedial location, it is called Margacnic hernia, dental hernia, anterolateral hernia. And in some cases, there will be only eventration of the diaphragm. That is plasticity of the muscle causing the bowels to go up. And due to defect in the esophageal hiatus, sliding, rolling, or mixed sliding and rolling type of hiatal hernia can occur. It is the schematic representation showing the various types of diaphragmatic hernia. It is the anteromedial rotation, that is the Margacnic hernia. And sometimes there may be complete agenesis of the diaphragm. The most common being the posterolateral hernia, which is the Bugdalac hernia. So this is the contrast picture showing the content of the bowel into the hemithorax. It is the left posterolateral hernia showing the defective diaphragm. So this is the types of hiatus hernia: sliding, rolling, and mixed sliding and rolling. So it is the schematic representation showing the left posterolateral diaphragmatic defect through which the large bowel, stomach, and small bowel enters into the left side of the hemithorax, causing the mediastinal shift. So congenital diaphragmatic hernia or CDH occurs in 1 of every 2,500 to 5,000 live births, and equal preponderance in male is to female ratio. The most common being the posterolateral left side posterolateral hernia, that is the Bugdalac hernia. 80 to 85% occurs on the left side, and 15 to 20% occurs on the right side. So embryologically, the diaphragm is derived from mainly 4 embryonic structures, that is from the septum transversum, pleuroperitoneal membranes, the mesoderm of the body wall, and the esophageal mesenchyme. So around 4 to 5 weeks of gestation, that is the septum transversum, forms like a semicircular cells, which then separates the heart from the abdominal liver. As the septum transversum develops, it separates the thoracic cavity from the peritoneal cavity, but it allows the pericardio-peritoneal canals on either side of the esophagus. Then again at the end of the 5th week, the pleuroperitoneal members develops along the line, connecting the root of the 12th rib with the tip of the 7th to 12th ribs, thus completing the thoracic cavity and abdominal cavity. Then eventually these pleuroperitoneal membranes grow ventrally and fuse with the septum transversum on the dorsal mesentery of the esophagus. So at 6 to 7 weeks of gestation, these pleuroperitoneal membranes close. The left side closes later than that of the right. The left and right cura of the diaphragm develops from the mesentery of the esophagus, and the mesoderm of the body wall forms the outer rim of the diaphragmatic muscle. Thus, any pathophysiology in the development of the pleuroperitoneal membrane leads to the defect in the developing diaphragm, which causes the communicating thoracic and the abdominal cavity, leading to herniation of the abdominal contents into the hemithorax. As a result of this bowel herniation, the compression on the developing lungs, both the lungs develops abnormality, the main pathophysiology being the pulmonary hypertension. The bronchi are less numerous and the number of alveoli is reduced, leading to the decreased alveolar capillary membrane for gaseous exchange. The pulmonary vessels are also mainly affected, and the cross-sectional area of the pulmonary vessels is reduced. And there is increase in muscular layer, resulting in the severe pulmonary hypertension. The main pathophysiology in CDH, apart from the compression and decreased development of the lung or lung hypoplasia, the main pathology being the pulmonary hypertension. So this will result in pulmonary hypertension, which leads to right to left shunts at the atrial and the ductal levels. This persistent fetal circulation then again leads to the right-sided heart failure. This visual results in progressive hypoxemia, hypercapnia, acidosis, and pulmonary hypertension results. So, the four main pathophysiology of the congenital diaphragmatic hernia involves the pulmonary hypoplasia, pulmonary hypertension, pulmonary immaturity, and surfactant deficiency. Coming to the clinical features, during antenatal ultrasound, it reveals polyhydramnios and an absent intra-abdominal gastric air bubble on the mediastinal septum and in some cases hydrops vitalis. It is an important question. At earliest 15 weeks of gestation, we can detect congenital diaphragmatic hernia in the antenatal period. So, depending upon the weeks of gestation, when we are detecting the CDH antenatally, the prognosis, if we the earlier the detection, the prognosis will be worse. But if develops on later weeks, after 20 weeks, then the prognosis will be somewhat good. So, after postnatal period, the child will present with respiratory distress and cyanosis in the first minutes or hours of life. So, clinically, when we examine, the abdominal will be scaphoid and the chest will be barrel-shaped chest. And the signs of respiratory distress will be obvious, such as retraction, cyanosis, and grunting respiration. There will be the poor air entry on the left side with the shift of the cardiac sound, that is called pseudo-dextrocardia. Then sometimes the patient may be present outside the neonatal period with the respiratory symptoms, intestinal obstruction, and bowel ischemia and necrosis with volvulus. This is the diagram showing the barrel-shaped chest with a scaphoid abdomen. So, in CDH, the mainly associated anomalies are cardiac anomalies, followed by genitourinary and chromosomal abnormalities. So, the management first, initially, when you suspecting CDH or antenatally disease diagnosis, bag and mask ventilation should be avoided. Intubation, it is carried out in two ways. In some centers, only the intubated child is intubated when there is some respiratory distress. In some centers, all cases are electively intubated just immediately after birth. And the nasogastric tube decompression of the stomach is must to prevent further compression of the lung and also the dextrocardia. Then arterial line should be maintained and also arterial blood gas analysis should be done to rule out the acidosis. Then urinary catheterization, then X-ray shows the herniation of the bowel into the hemithorax and the mediastinal septum. And echocardium should be done to rule out any cardiac anomalies and also importantly to rule out pulmonary hypertension. So this is the X-ray showing the Rayleigh tube in the stomach with the stomach herniated into the hemithorax and the Rayleigh tube is in the hemithorax. This is the right-sided defect with the right-sided hernia. In right sided, the most commonly there will be the liver and liver is herniated. So coming to the management, first the hemodynamic support should be given and the management of pulmonary hypertension should be started immediately. Why? With inhaled nitric oxide, sildenafil, milrinone, and prostaglandin ER are some of the agents used for primarily treating the pulmonary hypertension. Usually, in most of the centers, sildenafil is used. And for surfactant deficiencies, exogenous surfactant is given. When and where required, high frequency oscillatory ventilation, or in some cases, ECMO is necessary for the child with CDH. The criteria for ECMO, the child should have the weight more than 2 kg and there should not be no major intracranial hemorrhage or cranial. It should be ruled out on cranial ultrasound. And child should have been on mechanical ventilator support with less than 10 to 14 days. More than 14 days ventilator supports, then ECMO, there is of no use. And there should not be major congenital anomalies. In some cases, the fetal surgery is advocated when where there is an endoscopic occlusion of the fetal trachea, which results in the improvement in growth of the alveoli and bronchial tree. The surgical repair is the main mode of the treatment. Before surgical repair, the pulmonary hypertension, acidosis should be corrected, and the child should be maintained on the ventilator with low ventilatory settings. Then only we should, after correction of the pulmonary hypertension only, we should take up of the child for surgical repair. The surgical repair is open or thoracoscopic or laparoscopic CDH repair, in which the contents are reduced into the abdominal cavity and the defect is sutured. While in case of when there is a large defect, a prosthetic mesh can be kept or muscle flap can be used. So, coming to the complications, in the early postoperative period, there may be recurrent pulmonary hypertension and deterioration in respiratory mechanics, or in sometimes when there is the defect when the suturings are not made properly, recurrent congenital diaphragmatic hernia can occur. Sometimes there will be leakage of peritoneal fluid and blood into the thorax. Small bowel obstruction may occur secondary to the adjacent or valvulus. In most of the cases with the diaphragmatic hernia, the rotation of the bowel will be abnormal, so which leads to sometimes small rotation with valvulus of the bowels. So the long-term complications being the long-term pulmonary disease, which results in bronchopulmonary dysplasia, restrictive and obstructive lung diseases, and failure to thrive. And due to the hiatal discrepancy in the child with CDH, there will be functional anatomic esophageal abnormalities. And due to the surgical, there will be the altered musculoskeletal development, which results in thoracic scoliosis, pectus deformities, and a decreased thoracic cavity. In the long term, there will be the learning disability and behavioral problems. So, coming to the CDH, the most common questions being asked are the most common type of CDH, that is the left side posterolateral hernia, which is the Bach-Delac hernia, and it is usually diagnosed antenatally around 15 weeks of, as early as 15 weeks of gestation. The earlier the diagnosis, the worse the prognosis. Then main pathology playing the, apart from pulmonary hyperplasia, pulmonary hypertension being the main pathophysiology, and bag and mask ventilation should be avoided when and where and there is the decrease in the saturation of the child. Intubation is necessary. So surgical treatment either by laparoscopy or thoracoscopy or by laparotomy. Before taking the child for surgery, pulmonary hypertension should be corrected and lactic acidosis should be corrected. So the next topic being the congenital cystic lesions of the lung. The main common congenital cystic lesions are bronchogenic cyst, intralobar and extralobar sequestration, congenital pulmonary airway malformation, and congenital lobar emphysema. These are the four main congenital cystic lesions of the lung, which can be detected antenatally, and it is progressing in the postnatal period. The perinatal period, the following complications will be pleural effusions, polyhydramnias, hydrops vitalis, and pulmonary hypoplasia with the subsequent respiratory distress and airway obstruction. So coming to the topic one by one, first we can discuss about congenital lobar emphysema. It is a developmental anomaly of the lung, which is characterized by the lobar hyperinflation of the corresponding lobe. It is more common in the male. The prevalence is 1 in 20,000 to 1 in 30,000 individuals. The most common questions being asked is the side and which lobe is affected more frequently. While coming to the congenital lobar emphysema, left upper lobe is most frequently affected in 40 to 42% of the individuals, followed by the right middle lobe and right upper lobe. So, in the CLE says most common lobe being affected is the left upper lobe, followed by the right middle and right upper lobe. So there is an intrinsic absence or abnormality of the cartilage lungs, which is the deficiency in cartilage of the bronchial wall, which then leads to the hyperinflation of the lung. Other causes being the extraluminal obstruction, which leads to the compression of the affected bronchus by any abnormal blood vessels. Then other etiology being the congenital bronchial stenosis and the redundant bronchial mucosal flap and the polyalveolar lobe. These are the four postulated theories for CLD. The presentation is usually in 33% of the individuals it present at birth, and by 50% it is in 1 month of age. Then after 6 months of age, only 5% are reported. The severity is variable in different individuals. Most patients present with the moderate respiratory distress, and in some patients there will be the cyanosis and respiratory distress. In rare cases, it may be discovered asymptomatically in the chest X-ray, while in very rare individuals, it may be present with severe life-threatening respiratory distress if not detected antenatally. So the diagnosis being by the X-ray, it is showing the hyperinflation of the left upper lobe. So it is CT showing hyperinflation of the left upper lobe with the herniation into the of that lobe into the opposite side. So the surgical treatment is the main. It follows the lobectomy of the involved lobe. So in CLE, most common side affected is the left upper lobe. And the male is more commonly involved with a ratio of male to female ratio 3:1. It is due to the hyperinflation of the affected lobe. Then next is congenital cystic adenoid malformation. It is CCAM, or sometimes it is also called CPAM. Congenital cystic adenomatoid malformation. It is considered as the hamartomatous abnormality of the lung. That is, there is an abnormal tissue with an excess of one or more tissue component, which results from the adenoid proliferation of the terminal bronchioles, resulting in the formation of cyst with a consequent reduction in the alveolar growth. So, due to hamartomatous development, the normal alveolar growth will be reduced. So it generally communicates with the bronchial tree and derives blood supply from the pulmonary circulations. The main difference between the other congenital cyst and the adenomatoid malformation is that it receives blood supply from the pulmonary circulation, which is the main differential point between the sequestration and the cystic adenoid malformation. Well, in sequestration, there will be the systemic, it receives blood supply from the systemic vessels. While CCAM, there will be the blood supply from the pulmonary circulation and generally communicates with the bronchial tree. The incidence is 1 in 25,000 to 1 in 35,000 individuals. It occurs more often in males than in females, as such that of the CLE. It can affect both sides of the lung and any lobe with equal side preponderance. While in CLE, most common affected lobe is left upper lobe. In CCAM, both lobes and both sides can be affected equally. Then the classification of the CCAM. It is called Stocker's classification of cystic adenomatoid malformation classification. It is classified into three types: type 1, 2, and 3. Type 1 is the most common, occurring for 65% of the individuals. In this case, it is most commonly classified with the size of the cyst. In type 1, there will be the multiple large cells more than 2 cm in diameter, or it may be present as a single large cyst surrounded by numerous smaller cysts. These cysts are frequently lined by pseudostratified columnar epithelial cells, and it also produces mucin. The most common type is type 1 CCAM, accounts for 65%, and is associated with good prognosis. So this is the pictorial and X-ray representation showing the multiple large cysts more than 2 cm affecting the left upper lobe. So the next common is the type 2 CCAM. It is usually the size, the diameter of the size will be cyst will be 0.5 to 2 cm with the multiple small cysts. It is a relatively uniform cyst which also resembling the bronchioles. 60% of are associated with other congenital anomalies, especially in type 2 CCAM. Renal agenesis is most commonly associated. It is lined by cuboid columnar epithelium and have the fibromuscular wall. So this is the pictorial representation showing the multiple small cysts of equal size resembling that of the bronchioles of 0.5 to 2 centimeter. So type 3 comes. It is relatively rare, occurring 10% of the individuals. In this is the cyst are large and grossly look like a solid mass than that of the cyst. That is a microscopically small cyst of less than 0.5 centimeter in diameter. Consists of multiple microcysts. It looks like a solid mass. So these are the multiple microcysts which looking as a solid mass. So the three types, the type 1 being the most common and 65%, cysts are more than 2 centimeter in diameter, and the type 2 0.5 to 2 centimeter with equal sizes resembling that of the bronchioles. In type 3, the multiple small cysts looking as a solid mass. And the presentation is usually the postnasal presentation is with the respiratory distress. This is due to the cyst resulting in the compressing of the normal functioning lobe, resulting in pulmonary hypoplasia. And there will be the mediastinal shift of the opposite side. Sometimes there will be spontaneous pneumothorax, and sometimes there will be air trapping within the cyst, leading to the compression of the functional pulmonary tissue. In rare cases, there will be pleural effusion, triggering to the development of the height hospitalis. So, while the later presentation being the recurrent chest infection due to bronchial compression and air trapping, and also the inability to the clear secretions. In rare cases, malignant transformation is present. Otherwise, the child may present with cough, fever, and failure to thrive. In most of the cases, rarely there may be prenatal regression and complete restoration of the cecum has also been reported. So, what are the characteristic features which differentiate that of the cystic adenoid malformation from that of the other congenital cystic lesions? The following 5 characteristics, that is main is the absence of the bronchial cartilage and absence of bronchial tubular glands, and the presence of tall columnar mucous epithelium and overproduction of the thermal bronchial structures without any alveolar differentiation, and the massive enlargement of the affected lobe that displaces the other thoracic structures. These are the 5 main distinct features which differentiate cecum from other congenital lesions. So investigations being the antenatal ultrasound, postnatal ultrasound X-ray, and to clearly differentiate the size of the cyst and the affected lobe, CT scan can be done. This is the X-ray showing the left lower lobe being involved with multiple cysts. This is the cyst showing with air fluid level, which causes the relaying into the abscess. This is the CT picture showing the multiple cysts. So surgery is being the main treatment, as lobectomy of the involved lobe is advocated, which shows the multiple cysts. So cystic adenoid malformation, male cells are more prone than the female, 1.8 is to 1. It is classified based on the size of the cyst, that is the Stocker's classifications, into the 3 types, most common being the type 1, and most common associated anomaly is the renal agenesis, which is most common in the type 2 cyst. The treatment being the surgical excision of the affected lobe, that is the lobectomy. Next is the bronchogenic cyst. These are the congenital lesions which derived from the primary foregut. Prevalence is 1 in 42,000 to 1 in 68,000. It is the most common congenital intrathoracic cyst, which is the bronchogenic cyst. The lower lobes of both sides are most commonly involved. While in cecum, both sides, all lobes can be involved equally. In CLE, left upper lobe is most commonly involved. In bronchogenic cyst, lower lobes are most commonly involved. The cysts are typically unilocular and a few centimeters in size, round or oval, and filled with serous or proteinaceous fluid and less commonly hemorrhagic secretions. So embryology, coming to the embryology of development of the bronchogenic cyst. During embryonic development, the primitive foregut, which arises in the third week of the gestation and divides into the dorsal portion and the ventral portion. The dorsal portion, which elongates to form the esophagus, and the ventral portion, which differentiate into the tracheobronchial tree. The errors in developments of this ventral foregut, which will give rise to the bronchogenic cyst. So lesions arising before or during the separation of the embryonic foregut are situated in the mediastinum. Most of these cysts are located close to the trachea, near the carina or the main stem bronchi, and are often attached by a stalk or share a common wall with one of the major airways. Cecum also has a communication with the bronchial tree. So communication of the cyst with the bronchial tree is rare, but it may be shares a common wall with the major airways. So lesions arising after separations, that is before separations, are usually located close to the trachea or presenter in the mediastinum, that is the 30%. In most cases, in around 70%, the lesions are appear only after the separation of the ventral and dorsal foregut, which are frequently situated within the lungs. They are thought to result from an abnormal airway branching secondary to the defective epithelial or mesenchymal cell interaction during the 4th to 7th week of life. These intrapulmonary bronchogenesis will often communicate with the bronchial tree, and about 2/3 of them will be aerated. Intraparenchymal cysts have been consistently reported to be lined by respiratory epithelium and cartilage. So, in the bronchogenesis in the right middle lobe. In the another picture is in the left upper lobe. So, the clinical presentation, the bronchogenesis are frequently asymptomatic, usually discovered only incidentally on the chest X-ray. Sometimes it may be present with respiratory distress or recurrent chest infections. It may also associate with chest pain, cough, dyspnea, and the dysphagia. Hemorrhage has been reported in the cyst with ectopic gastric mucosa. Rare cases, adenocarcinoma or rhabdomyosarcoma has been reported. The investigation, most common being the antenatal ultrasound. Postnatally X-ray, this typically shows a sharply demarcated spherical mass of variable size. Most commonly location is the medial mediastinum, just in front of the trachea, or sometimes in the main stem bronchi at the carinal level. When the cyst communicates with the tracheobronchial tree, an air fluid level may be seen within the cyst. So sometimes esophageography is necessary to see any eccentric compression of the esophagus, and CT scan is the final diagnosis. The treatment being the segmentectomy or the lobectomy of the involved lobe. So bronchogenesis, there are two types. During embryologically, the foregut is divided into ventral and dorsal portion. The dorsal portion is develops into the esophagus and the ventral portion into the tracheobronchial tree. The defect in this branching of the ventral portion result in the development of bronchogenic cyst. This ventral foregut, when the lesions occurs at the end before branching or before separation of the embryonic foregut, it will be in the mediastinum, which is around 30%. While when the lesions appears after the branching of the ventral foregut, it is most commonly 70%, which is frequently situating in the lungs. So when the lesions appears before the separation of the foregut, the lesions will be in the mediastinum and there will be no communication with the tracheobronchial tree. The lesions appears after the separation of the foregut. The lesions will be in the lung parenchyma with the lung epithelium, and it also has a communication with the tracheobronchial tree. So the next congenital lesions is among the four we have discussed about congenital lobar emphysema, cecum, bronchogenesis, and the fourth being the pulmonary sequestration. It is characterized by a non-functioning mass of the normal lung tissue, which lacks the communication with the tracheobronchial tree. It receives arterial blood supply from the systemic circulation, and the left lower lobe is the most common site involved. So Among the lobes involved, CLA's left upper lobe is most common, while in CCAM, both sides, all lobes are equally involved. In bronchogenesis, most commonly lower lobes are involved, while in the pulmonary sequestration, left lower lobe is the most common site. So coming to the embryology of the sequestration, an accessory lung bed that develops from the ventral aspect of the primitive foregut. This pleuroperitoneal tissue from this additional lung bed, which migrates in the caudal direction with the normally developing lung. So it receives blood supply from the vessels, thus connect to the aorta, that is from the systemic blood supply, and cover the primitive foregut. This attachment to the aorta remain and subsequently form the systemic arterial supply of the sequestration. So when this accessory lung bed develops yearly during the development of the foregut, it results in the intrapulmonary sequestration, while the development of accessory in the later stage leading to the extrapulmonary sequestration. In pulmonary sequestration, there are two types, intrapulmonary and extrapulmonary. And the development of accessory lung bed is yearly in the embryological period. It results in intrapulmonary sequestration, while in the later period, it results in extrapulmonary sequestration. So the extrapulmonary sequestration is encased with its own pleura. Both types of sequestration usually have arterial supply from the thoracic or the abdominal aorta. Rarely the celiac, hello. Rarely the celiac gases, internal mammary, subclavian or renal artery may be involved. Intrapulmonary sequestration occurs within the visceral pleura of the normal lung tissue and usually has no communication with the tracheobronchial tree. Coming to the intralobar sequestration, it usually located within the normal lobe and it lacks its own visceral pleura. Its arterial supply is derived from the descending thoracic aorta, abdominal aorta, or celiac gases, or the intercostal arteries. Venous drainage is usually to the left atrium via pulmonary veins or via inferior vena cava and superior vena cava or azygos vein. Usually, the differentiating feature in the left lobar sequestration is the arterial supply is from the systemic supply, but the venous drainage is through the pulmonary veins or the inferior or superior vena cava. It accounts for 75% of the all sequestration, and the male to female preponderance is equal. It is usually located in the paravertebral region in the posterior segment of the left upper lobe. It is rarely associated with other developmental anomalies. It presents late in adolescence or adulthood with recurrent chest infection. While interlobar sequestration is present within the lung parenchyma, extralobar is located outside the normal lung and it has its own visceral pleura. It accounts for 25%. Males are most common being hello. Does someone have a question? Hello. Hello. It's not clearly audible. Hello. 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 Does somebody have any doubt? Or can we proceed? Okay, coming to the extralobar sequestration. It is located outside the normal lung and has its own visceral pleura. It accounts for 25% of all sequestration. The males being most commonly affected with 4:1 ratio. It is commonly related to the left hemidiaphragm in 80 to 90% of the cases. The mass may be closely associated with the esophagus, and in some cases, there may be fistula between the pulmonary sequestration and to the esophagus. It may present as subdiaphragmatic or in the retroperitoneal mass in 10% of the cases. So, the arterial supply is mainly from an afferent vessels arising from the thoracic aorta or the abdominal aorta. It drains via the systemic venous system to the right atrium, commonly the inferior vena cava or the azygos veins, and rarely via the pulmonary veins. While the congenital anomalies are rare in intrapulmonary sequestration, the congenital anomalies are more frequent in the extrapulmonary sequestration. So, and there is embryological development of the axillary lung bud early in the intrapartum period. It leads to intrapulmonary sequestration, while late in the pregnancy it develops into the extrapulmonary sequestration. The most common difference between the extrapulmonary sequestration with have its own visceral pleura, while intrapulmonary lacks the visceral pleura, and both have the systemic arterial supply. While intrapulmonary sequestration is more common, that is most commonly affected in 70% of the individuals, and the congenital anomalies are very much less common in intrapulmonary sequestration, while the extrapulmonary sequestration, more than 60% of the individuals, there are other congenital abnormalities. So the diagnosis is by ultrasound X-ray. In some cases, the arteriography is necessary to differentiate its blood supply, that is from the systemic blood supply, and some cases CT scan is done. So this is the laparoscopic picture showing the apparent vessels supplying the affected lobe. So while the treatment for other congenital lesions being the lobectomy, the involved segment alone can be resected in case of sequestration. So the segmentectomy is the treatment of choice. So among the congenital lung lesions, the most common are four. It is bronchogenic cyst, cystic adenine malformation, or otherwise called congenital cystic adenomyosis TCAM. Then pulmonary sequestrations and congenital lobar emphysema. The most commonly asked questions are affected lobes in these types and the name of the classification of the CCAM and the systemic or pulmonary vascular supplies. These are the most commonly asked questions. So, coming to the next topic, apart from that is the tracheoesophageal fistula. The incidence is 1,500 to 3,000 live births, most commonly affecting the male. In 1/3 of the infants, there will be a low birth weight, and in 60 to 70% of the cases, there will be the associated anomaly. The embryology, during the 4th and 5th week of the embryological development, the trachea forms a ventral diverticulum from the primitive pharynx. This tracheoesophageal septum develops at the site where the longitudinal tracheoesophageal poles fuse together. Then this septum then divides the foregut into the ventral portion, that is the laryngotracheal tube, and the dorsal portion, which forms the esophagus. This esophageal atresia results if the tracheoesophageal septum is deviated posteriorly. This deviation, which causes incomplete separation of the esophagus from the laryngotracheal tube, and results in the concurrent tracheoesophageal fistula. So during the 4th and 5th week of embryonic development, this ventral diverticulum and there is the defect in when the foregut division into the ventral and dorsal portion, and there is deviation. It results in the incomplete separation and forming the esophageal atresia and the communication to the tracheal tree, leading to tracheoesophageal fistula. Rarely, without the communication with the tracheobronchial tree, only esophageal atresia may be occur. In these cases, atresia is attributed to the failure of the recanalization of the esophagus during the 8th week of development, and so it is usually not associated with TEF. So the embryology for pure esophageal atresia without the TEF is that of the failure in the recanalization of the esophagus. So these are the types. The most common is the C type, and there is the upper blind ending pouch and the lower pouch with the fistula connecting to the tracheobronchial tree. That is the C type, which is 86%. The C type of TEF is the most common type. The others being the pure esophageal atresia and upper pouch communicating the tracheobronchial tree with lower blind ending pouch, or in some cases there may be the H fistula. That is, there is a continuation of the esophageal lumen with fistulous connection to the tracheal tree. The associated anomalies are more common with the tracheoesophageal fistula, more common being the congenital heart malformation, such as the ventricular septal defect, PDA, which is patent ductus arteriosus, or TOF, right-sided aortic arch. So before going for the surgery, the main important thing is right side aortic arch should be ruled out and other congenital heart lesions should be diagnosed. And associated gastrointestinal anomalies, which include the imperforate anus, duodenal atresia, and malrotation. The musculoskeletal defects are equitable anomalies and the defects of the ribs and extremities. Mostly, there will be the extra 13th pair of ribs will be there. The urinary tract malformation are also associated with TEF, such as hypospedia, horseshoe kidney, and renal agenesis. The most common associated anomaly with the TEF is the cardiac defects, that is VSD and VD. The clinical features, how will you initial presentation of the TEF? Sometimes it may be diagnosed antenatally, but in postnatal period, there will be the drooling or excessive salivation, which is frequently accompanied by choking, coughing, and sneezing of the newborn child. So the child should not be fed. When feeding is attempted, the child develops chokes and cough and becomes cyanotics. You should suspect TEF, and there will be in H-type fistula, there will be recurrent aspiration due to the communication, and the recurrent chest infection will be there. So when there is excessive salivation with frequent choking and coughing, you should rule out tracheoesophageal fistula in the newborn. Prenatally, the ultrasonographic findings are polyhydramnios on the proximally dilated upper pouch and the smaller absent gastric bubble. And the failure to pass the nasogastric tube and coiling of the tube in the upper pouch is the diagnostic postnatally. So we should failure to introduce the nasogastric tube into the stomach. This should raise the suspicion, and X-ray to be taken. In X-ray, we can see the coiling of the nasogastric tube in the upper pouch. So echo should be done to rule out cardiac anomalies. So this is the X-ray showing the coiling of the nasogastric tube at the cervical level itself, here and here. So which confirms the esophageal atresia. The most common being the tracheoesophageal fistula. So what are the other features we should look in the X-ray apart from the coiling of the tube in the X-ray taken for the TEF? The main is the coiling of nasogastric tube, which results in the diagnosis of the tracheoesophageal fistula or esophageal atresia. Then you should look for the distal air column. When the distal air column is present, usually it is the type C, which is distal pouches connected to the trachea, resulting in tracheoesophageal fistula. In some rare cases, in that is of the pure esophageal atresia, the distal air column will not be there. That is, gastric bubble could not be there due to atresia. So in H-type fistulas, there are various contrast enhanced studies such as pull-out esophagogram with fluoroscopic control should be done to rule out the communication to the trachea. Or endoscopy or bronchoscopy may be performed to locate the site of the H-type fistula. This is the pull-out esophagogram, that is, the nasogastric tube introduced into the esophagus and the dye is injected while pulling out the nasogastric tube, and it is studied under fluoroscopic control. So it shows the fistulous connection from the esophagus into the tracheal tree and the spillage of contrast material into the trachea onto the bronchus, into the lungs. So the treatment is usually the surgery, which involves the division of the fistula And after ligating, it's tracheal end, the stretching the two ends of the esophagus and the primary single layer into an anastomosis. So this anastomosis is done over the nasogastric tube, which is passed into the stomach, and it can be used to decompress the stomach or for the early post-operative feeding. And the extrapleural chest tube is left after surgery to allow for drainage of some leaky occur. So the division of the fistula and primary anastomosis with nasogastric tube stent and also ICD, it is the main treatment. But when there is a long gap, usually the single layer anastomosis end to end. So when there is long gap esophageal atresia, the primary anastomosis could not be there. What is long gap? When a gap of length exceeding 4 centimeters, or when the gap between the upper pouch and the lower pouch is greater than the two vertebral bodies, or the upper pouch is above the level of the inlet, it is called long gap esophageal atresia. So when it is to be classified as long gap, the gap of should be exceed 4 centimeter, or gap should be greater than two vertebral bodies, or upper pouch is situated level above the thoracic inlet, or classified as long gap esophageal atresia. So in these cases, we should delay the repair, waiting for the esophageal ends to grow closer, or can be done by esophageal lengthening procedures. Some of the procedures such as Kimura, levaditis, or focus technique. Initially, primary esophagostomy, that is to prevent the spillage of saliva into the tracheobronchial tree. The upper pouch, distal pouch is brought out as esophagostomy for the drainage of saliva, and the gasostomy is done for the feeding purpose. Then later stage gastric pull-up or subsequent esophageal replacement procedure can done at later stage. So the complications after TF repair, the early complications being the anastomotic clip, which is in 10 to 20%. The current TF can occur in 3 to 10% of the individuals, and the esophageal strictures is the most common complication, seeing up to 40% of the individuals. The late complications due to stretching of the gastroesophageal junction during anastomosis, so resulting in gastroesophageal reflux in up to 35 to 50% of the children, and the esophageal motility dysfunction in 75%, and tracheomalacia in 20% of the individuals. So in tracheoesophageal fistula, most common type is being the type C, which is upper blinding pouch with the lower pouch communicating to the tracheoesophageal fistula. It is the most common type of TF, that is the type C. And the most common congenital association between the cardiac malformations, that is the VSD and the PDA, is the most common congenital association associated with the TF. Then clinical picture being the drooling of saliva, which is frequently accompanied by choking or coughing when the feeding is attempted. Oiling of the nasogastric tube is the diagnostic of that of the esophageal atresia in the upper pouch. So when it comes to when it's called longer, it is when the gap exceeds 4 centimeter or gap greater than two vertebral bodies, or the upper pouch is above the thoracic inlet. It is called long gap esophageal atresia. So the next topic is hypertrophic pylori stenosis. The most common question asked is electrolyte abnormality in hypertrophic pylori stenosis. This most commonly boys, first born boys are most commonly affected. It is there more commonly 4 times than that of the females. Usually occurs, the child will be normal in the first week of life, then develops projectile vomiting from the second week up to the 8th week. It is most frequently in 1 in 300 to 900 live births. So the pathology will be a loss of electrolytes due to vomiting resulting in alkalosis, hypochloremia, and hypokalemia. So in blood, it results in metabolic alkalosis. The renal tends to compensate the loss for hydrogen and potassium ions. So initially it conserves the sodium, so resulting in another hypokalemia, and already the potassium is lost during vomiting. So again it results in conserving the sodium and potassium, resulting in loss of H plus ions, resulting in paradoxical aciduria. So the electrolyte abnormality, most common being the hypokalemic, hypochloremic alkalosis with paradoxical aciduria. So the signs and symptoms most commonly is progressively projectile non-bile stain vomiting. The child remains hungry and takes food immediately after vomiting. There will be more dehydration, poor weight gain and malnutrition. While the age progress or weeks the progress, there will be the visible gastric peristalsis traveling from the left to right. And while palpation, there will be the palpable pyloric mass, or sometimes called olive sign. It is felt in the right upper abdomen, especially after vomiting and during a test feed. In rare cases, indirect hyperbilirubinemia may be increased by 1 to 2% of the individuals. So the diagnosis by the careful history taken and physical examination. History is non-bilious projectile vomiting, followed by dehydration, and the clinically palpable olive mass with the specific gastric vessels may be there. An X-ray which shows the hugely dilated stomach bubble. Ultrasonography, you should assess the pyloric length and the thickness. When the pyloric muscle thickness is more than 5 mm and the pyloric channel length is more than 15 mm, then the hypertrophic pyloric stenosis is confirmed. The blood test shows the hypochloremic metabolic alkalosis. So this is the X-ray picture of hypertrophic pyloric stenosis showing the hugely dilated stomach. So the treatment, first we should correct the dehydration and alkalosis, which is the primary mode of treatment. After correction of the dehydration and alkalosis, then only we will go for proceed with surgery. Usually, it should be accomplished in 24 to 48 hours using half normal saline with potassium supplement. And sometimes intravenous and oral atropine are tried. First, most common proposed management of IHPS is the Ramstead pyloromyotomy. This is the standard treatment. After pyloromyotomy, the only muscles is incised so that the bulging out of the mucosa, resulting in the decompression of the involved segment, resulting in free flow of passage of feeding into the from stomach into the duodenum. After pyloromyotomy, the feeding can be initiated within 4 to 8 hours after recovery from anesthesia. So this is the picture showing laparoscopic pyloromyotomy knife. The incision is made in the muscle seromuscular layer, and the seromuscular layer is split to see the mucosal bulge. Once the mucosal bulge is visible, then it is the adequate pyloromyotomy. Okay, next topic will be the neonatal intestinal obstruction. We can continue after the 10 minutes break. After the 10 minutes break, we can start neonatal intestinal obstruction. Thank you. The differential diagnosis of the neonatal intestinal obstructions is
Slides not moving.
now the slides are moving.
No, sir. Still cystic hygroma issue.
neonatal intestinal obstruction. The differential diagnosis of neonatal intestinal obstruction being the first is most common is atresia and stenosis, which involves the duodenum, small bowel, and that of the colon. The next common being the intestinal malrotation and meconium ileus. In some cases, the children will present with small left colon syndrome that is born to the diabetic mother, the meconial plug syndrome, volvulus or internal herniation, Hirschsprung disease, anorectal anomaly, and necrotizing enterocolitis. We are going to see each topic one by one. So, the whole in neonatal intestinal obstruction, the presentation will be with the bilious vomiting or aspirate. Unless otherwise proved, bilious vomiting is a surgical emergency and it should be considered as a neonatal intestinal obstruction. The presenting symptoms could be of any combination of the following. Main one is the bilious vomiting and abdominal distension. While in that of the distal intestinal obstruction, the abdominal distension will be more, followed by the vomiting. While in the proximal intestinal obstruction, only upper abdominal distension will be there, while the vomiting may progress early. And other features are delayed passage of meconium or passage of grayish white pellets only. In case of atresia, only the pellets will be, mucus will be displaced per rectum and sepsis. So, while taking the history, we should see the length of the pregnancy, antenatal and family history, maternal diabetes, passage of meconium, passage of plaque of meconium, if the baby has passed anything rectally, or results of the antenatal ultrasound. This should be taken into account the history. With the length of the pregnancy, the preterm, usually there will be the premature ganglionic cells in the bowel with disabled motility. In antenatal sepsis or family history, you should rule out chromosomal anomalies. In maternal diabetics, the small colon syndrome is most common. With the history of passage of meconium, when there is non-passage of meconium or delayed passage of meconium, Hirschsprung's disease should be ruled out. When there is a plaque of meconium is passed, then meconium plaque syndrome is considered. The child has not passed anything apart from the white mucus-like material, then atresia should be considered. And the antenatal ultrasound results should be verified. So postnatally, while examination, the first examination in case of when you suspect neonatal intestinal obstruction, to look for the presence of the anus. When there is the absent anus or some fistula-like opening and not the usual position of the anus, then it is comes under the anorectal malformation. When the anus is normally placed or normally present, then the other cause of intestinal obstruction should be ruled out. Then the extent of the abdominal distension should be done. In case of upper abdominal distension such as duodenal obstruction, there will be no distension with only vomiting. Early and upper abdominal distension with presence with the proximal intestinal obstruction. While there with more distal obstruction, there is generalized and the obstruction is slow to appear. Then you should look for the palpable bowel loops, erythema and tenderness of the abdominal wall, and the extent of the dehydration and the associated anomalies. Then coming to the imaging studies, first for all the individuals considering neonatal obstruction, the plain X-ray abdomen should be done. In that, in special cases, lateral decubitus film is done. In case of the NEC, to rule out pneumoperitoneum, on the invertogram or prone cross table lateral film is done for anorectal malformation to differentiate the high intermediate from the low anomaly. Then one should see the bowel gas pattern in the X-rays. In a normal abdomen, the gas pattern looks like a small equal size hexagons which is distributed uniformly across the abdomen. When any loop is dilated more than the size of the thumb in the newborn period, it is considered abnormal. In case of NECs, there will be the fixed dilated bowel loops. Then the amount of abdominal air should be done, which is when there is a single loop, it is single bubble, it is considered duodenal atresia. This pyloric stenosis. If there is double bubble, then you suspect duodenal atresia. In the earlier upper jejunal atresia, there will be the triple bubble. So number of air fluid levels and free air, and in some cases of meconium complex or ruptured meconium ileus, there will be the calcifications will be seen. So these are the pictures showing the distal bowel obstruction or the dilatation of the proximal bowels, and this is the picture showing the proximal obstruction. So the contrast studies, the contrast edema acts just not only for the diagnosis, but in many cases it can be act as a therapeutic measure in case of meconium plug, small left colon syndrome, and the meconium ileus. While contrast upper gastrointestinal studies are needed in cases when you suspect malrotation or sometimes to characterize duodenal obstruction. So coming to the individual topics, first one is the duodenal atresia. Failure of it is due to the failure of recanalization of the solid part of the gastrointestinal tract. So embryology of the duodenal atresia is due to the defect in or failure in the recanalization of the solid part of the GI tract. Usually affects the second part of the duodenum, and the incidence is 1 in 6,000 birth. Approximately 1/3 of the patient with the duodenal atresia have Down syndrome. Most common congenital anomaly associated with duodenal atresia is Down syndrome. It is one of the important questions. So it may be complete or incomplete. The complete duodenal atresia is caused by complete duodenal diaphragm or atresia. While in case of incomplete duodenal obstruction or the partial duodenal, it is caused due to duodenal stenosis, or when there is a duodenal diaphragm with a central hole, or maybe due to the eccentric causes such as latch bends, duplication cyst, portal vein causing anterior to the duodenum. These are the eccentric causes causing partial duodenal obstruction. Sometimes annular pancreas will also cause eccentric duodenal obstruction. The presentation, the antenatal ultrasound, you can see the double bubble. And postnatally, there will be the early onset of bilious vomiting and there will be the feeding intolerance. Rarely, when the duodenal atresia is proximal to the second part or proximal to the common bile duct, then there will be the vomiting is non-bilious. Most common associated congenital anomaly is Down syndrome. More than 1/3 of the individuals. More commonly, there will be the upper abdominal distension or scaphoid abdomen if the stomach is empty or the child is on nasogastric training. So associated anomalies are Down syndrome, congenital heart disease, annular pancreas, intestinal malrotation, esophageal atresia, or PEF. So this is the X-ray picture showing the duodenal atresia with double bubble shape. One is the stomach bubble, another is the proximal duodenal bubble. So this is the contrast meal showing the double bubble with the dilated stomach and the upper part of the duodenum. But there is a small amount of the contrast visible lower down. So it is most commonly being the duodenal diaphragm with some central hole. So through that hole, the some amount of contrast is leaking. So it is not complete obstruction. It is an incomplete obstruction. That is the duodenal diaphragm with some hole in it. So treatment will be surgical, which is chimeras. Chimeras means duodenal-duodenostomy, or sometimes a side-to-side duodenal-jejunostomy can be done, or continuous seroral lining points towards the duodenal web and the duodenectomy with the excision of the web can be done, but immense care should be done to avoid injury to the amplifier. Then the duodenum is closed transversely. In the huge dilated duodenum, tapering duodenoplasty can be done. It is utmost necessary while doing duodenostomy that the presence of the second distal atresia should be ruled out. So this is the pictorial X-ray showing the double bubble appearance with duodenal atresia, and the pictorial representation showing the Kimura surgery. That is the transverse incision in the upper part and the longitudinal incision in the lower dome. So it is the humerus, the transverse incision in the upper dilated duodenal pouch, and the longitudinal ventral incision in the lower pouch, and anastomosing the two parts. That is the humerus duodenal-duodenostomach. So then come to the jejunal-ileal atresia. The incidence of jejunal and ileal atresia ranges from 1 in 1500 to 12,000 live births. The atresia accounts for 95% of the jejunal-ileal obstructions, and stenosis accounts for remaining 5% of the cases. So jejunal-ileal obstructions can be differentiated into atresia and stenosis. So stenosis accounts for only 5%. Atresia are most common, accounting for 95% of the obstructions. The ileum is slightly more affected when compared to the jejunum. So among the atresia, jejunal atresia are most common atresia. So what are the etiologies or embryological explanation for the jejunal atresia? While for the duodenal atresia, the etiology be the failure of recanalization of the lumen of the diaphragm. But in jejunal atresia, the main proposed theory is an intrauterine vascular accident leading to the atresia. Others are in utero intussusception or intestinal perforation or segmental volvulus or thromboembolism. These are the other proposed theories. The main proposed etiology is the intrauterine vascular accident leading to the atresia of that part of the bowel. So there are two broad types, atresia and stenosis. Atresia accounts for more than 95% of the jejunal obstructions. Stenosis only for 5%. What is a stenosis? The stenosis is a localized narrowing of the bowel without any layers of the bowel continuity and an intact mesentery. In this case, the other proximal dilated intestine is in continuity with that of the distal non-dilated bowel, and there will be a small narrow segment of the small lumen between them. This is stenosis. In stenosis, there will be the localized narrowing without the loss of bowel or mesentery. The proximal is dilated and the distal is non-dilated with a narrow segment between the two. Coming to the atresia, these are the type 1 atresia, and there is the intact bowel continuity with intact mesentery, but with the definitive obstruction between the two. So in type 2 jejunal atresia, hello, hello, that A and B is a diagram, not types. In type, there is pictorial representation, that's all. In the type 1, there is the proximal dilated jejunal portion with continuity of the bowel with intact mesentery. While in type 2, there will be a fibrous stand between the distal part and the proximal dilated part, but the mesentery is intact. This is the type 2. In type 3A, there is no fibrous band, but also V-shaped defect of the mesentery. This is the type 3A. And there is a V-shaped type of the mesenteric defect with discontinuation of the upper and lower atretic segment. The upper one will be dilated and the distal will be small. In type 3 or apple pill deformity. So this is the apple pill atresia of the type 3B. When there is in the type 3, there will be the apple pill deformity with that of the main thing is the blood supply is from retrograde with the superior mesenteric vessels or the ileocholic artery. So type 3B is the apple pill deformity with the retrograde blood supply from the ileocholic artery. So this is the picture. Based on the entry, there will be the apple pay with stenosis. So type 4 is the multiple industrial atresia, which comes under type 4.
So very sorry. ਤੁਸੀਂ ਤਾਂ ਮੈਨੂੰ ਦੇ ਦੇ ਮੈਂ ਮੰਨ ਦਿੰਦੀ ਸਾਰੂ
What?
ਪੈਸਾ ਨੂੰ ਮੈਂ ਮੰਨ ਦਿੰਦਾ ਪੁੱਛ ਤੂੰ ਲਾ ਦੇ
So,
ਘੱਟ ਸਭ ਲਾ ਦੇ ਸਾਰੂ
what?
ਆ ਫਸਟ ਤੋਂ ਸੁੱਕੇ ਨਹੀਂ ਹੋਣੇ ਯਾਰ ਇਹ ਬਾਰਿਸ਼ ਦਾ ਧਿਆਨ ਰੱਖੋ ਜੇ ਬਾਰਿਸ਼ ਨਾ ਪਵੇ ਕਿਤੇ ਮੈਨੂੰ ਸੁਣ ਲੈਂਦੇ ਨਾ ਖਤਮ ਹੋ ਜਾਣੀ ਕਲਾਸ ਫਿਰ ਸੁਣ ਲੈਂਦੇ ਤੁਹਾਨੂੰ ਆਣਾ ਫੋਨ ਕਿ ਨਹੀਂ ਆਣਾ
Hello. Someone is unmuted the audio, I think so.
ਹਾਂ ਨਹੀਂ ਸਗੋਂ
Just wait for a while, I am muting them.
Someone has unmuted the audio. Hello.
Yeah, I have muted them. Now we can continue. I have muted them.
Okay. Thank you. So the type of the atresia, the type 1 being the intact mesentery with only the atresia at the ball with continuation of the ball wall. In type 2, there is a fibrous stand between the proximal dilated segment and distal atretic segment with the intact mesentery. In type 3A, the proximal segment is dilated and there is the distal atretic segment with a V-shaped mesenteric defect. So the V-shaped mesenteric defect if present, it comes under type 3A. The apple pill deformity, it comes under type 3B with a retrograde blood supply. So in type 4 jejunal atresia, it is the multiple atretic segment, is type 4. So pathophysiology is most common being the intrapartum vascular accident in jejunal atresia, while that of duodenal atresia, it is the failure of recanalization of the duodenal lumen. So this is the picture showing the multiple atresia. So coming to the clinical features, in antenatal, there will be the history of polyhydramnios. It is associated with prematurity and low birth weight. Postnatally, there will be the bilious vomiting and abdominal distension. In some patient, it is associated with jaundice and the failure to pass meconium in the first day of life. Only the mucus-like discharge will be present, and there will be the failure to passage the meconium. So clinically, when you see, there will be the intestinal loop as well as peristalsis can be visible. An excessively dilated proximal bowel segment may undergo torsion, necrosis, or perforation. In these cases, the patient will be septic and dehydrated, and the abdominal wall may be erythematous. So, investigations: ultrasound, X-ray showing the double bubble in duodenal atresia, triple bubble in proximal jejunal atresia. While doing the contrast study, that is the contrast enema, there will be the distal unused colon distal to the atresia. So this is the picture showing the section of the bowel. This is the contrast study showing the distal unused colon distal to the atresia. When the colon diameter is less than 1 centimeter, then it is called small colon. So this is the contrast enema picture showing the distal unused colon distal to the atresia. So the treatment depends on the early diagnosis, proper preoperative stabilization of the child, and the right size of the surgical procedure, and the good post-operative care. So the main treatment is the for proximal intestinal atresia, resection and anastomosis of the bowel can be done or kept as ostomy. Usually for the distal atresia, we can brought the two lobes as ostomy. For proximal atresia, due to excessive electrode loss, if we the primary anastomosis can be considered. Then next is the apart from atresia, next common cause for neonatal intestinal obstruction is the malrotation and the midgut volvulus. It occurs in 1 in 6,000 live births. Male to female ratio is 2:1. As many as 40% of the patients with malrotation is present within the first week of life. It is diagnosed in 50% by 1 month and is diagnosed in 75% by 1 year. In some cases, even in adults, and some malrotations are diagnosed only after presenting with volvulus. So, to know about the malrotation, normal rotation of the bowel should be considered. That is, bowel is considered as the two loops. That is the proximal duodenojejunal loop and the distal cecocolic loop with goes for rotation around the axis of the superior mesenteric vessels. So the bowel is considered as the two loops that goes for the rotation around the axis of the superior mesenteric vessels. Proximal is the duodenojejunal loop, distal is the cecocolic loop. During embryonic stage, in the first stage, the bowels comes outside the abdomen where the proximal duodenojejunal loop goes for the 90-degree anti-clockwise rotation. So there will be the proximal duodenojejunal loop will be present to the right of the superior mesenteric vessels. Then again 90-degree rotation while returning of the bowel into the abdomen. Then the proximal duodenojejunal loop will lie behind the superior mesenteric vessels and again 90-degree rotation resulting in the duodenojejunal loop behind the superior mesenteric vessels and to the left. So totally 270-degree rotations takes place, normal rotation in an anti-clockwise direction. So 270-degree rotation takes place in an anti-clockwise direction during the development as a superior mesenteric vessels as an axis, resulting in duodenojejunal loop being brought down behind the superior mesenteric vessels and to the left of the vertebra, while cecocolic loop passing in front of the superior vessels and comes and fits in the right area fossa. So any disturbance in this normal rotation can result in either non-rotation or incomplete rotation, or in the third stage, incomplete fixation. So it may result in acute midgut volvulus. It is commonly seen in those less than 1 year of age. In this type of children, there will be the sudden onset of bilious vomiting and commonly abdominal distension. Child will be normal, then sudden onset of bilious vomiting will be there and the abdominal distension will be present. In rare cases, bleeding per rectum and hematemesis can occur when it goes for torsion and when ischemic changes develops. And the signs of peritonitis and shock is present in case of acute midgut volvulus. In some cases, there will be the chronic midgut volvulus. It results from intermittent or partial discharging of the bowel leading to lymphatic and venous obstruction. So it results in recurrent abdominal pain and malabsorption. So there will be the recurrent attacks of diarrhea alternating with constipation, intolerance of the solid food, obstructive jaundice, and gastroesophageal reflux. The patients or children will appear normal between the attacks of the chronic midgut volvulus, but during an attack, the picture is similar to that of the acute midgut volvulus. So then another one is the acute duodenal obstruction. When the malrotation is usually associated with the Latz bands, which runs from the cecocolic group over the duodenum, causing obstruction into the lateral peritoneal wall. So which cause compression of the second part of the duodenum. This leads to the extrinsic compression of the duodenum, resulting in the acute duodenal obstruction. It is usually present in infants and presents with bilious vomiting. And sometimes The age range diagnosis range from infancy to the preschoolers in case of chronic duodenal obstruction, but due to latch ones, but the not obstruction is not complete. So in that case, if child will present as bilious vomiting, intermittent abdominal pain, and failure to thrive. In some rare cases, in the defect of the fixation, there will be the internal hernia. There are two types of hernias. This results from the herniation of bowels into the recesses in the abdominal cavity. It presents as recurrent abdominal pain, vomiting, and constipation. It may progress from an intermittent picture to the acute presentation as a midget volvulus. So the investigations are X-ray. In X-ray, it looks like absolutely yes. Only the gastric bubble will be visible, and the distal gasless abdomen in case of malrotation with acute midgut volvulus, there will be the distal absent gas shadow. The contrast study also reveals only the spaces of small element into the distally, but hugely dilated stomach. In ultrasound, there will be the alteration in the superior mesenteric axis of the superior mesenteric artery and the superior mesenteric vein. So when there is the alteration or reversal of the axis of superior mesenteric artery, malrotation should be suspected. It is the X-ray showing hugely dilated stomach with distally absent air shadow that the child will present with malrotation going for the acute volvulus. So this is the barium solar picture showing the hugely dilated stomach with passage of contrast material into the distal bowel. You can clearly see that the small bowels are placed to the right of the abdomen. Usually, the large bowels will be in the distal part and the small bowels in the middle part. But in case of malrotation, there will be the non-rotation and non-fixation. So the small bowel loops on the right and the large bowel loops will be on the left. This is the barium swallow picture clearly showing the dilated stomach with small bowels to the left of the small bowels to the right side of the abdomen. So main management first is nasogastric tube or aerogastric tube should be inserted and the stomach is decompressed and the child is kept in fever. Then intravenous fluids and alcoholic visits should be corrected. Then antibiotics, broad spectrum antibiotics are administered for positive, negative, and anaerobic organisms. Then central venous catheter is placed. Then coming to the surgery for malrotation or with volvulus, it is the Latz procedure. If there is the volvulus, first reduction of the volvulus should be done. Normally, the bowel rotation will be in the 270-degree anti-clockwise rotation. In case of malrotation, it will not be there, and the volvulus will be in the clockwise rotation around the superior mesenteric vessels due to narrow based mesentery. In case of malrotation of the bowel, there will be the narrow based mesentery. So there will be the volvulus in the clockwise direction. So the reduction of the volvulus should be in the anti-clockwise. So normal rotation will be in the anti-clockwise direction, 270-degree, while that of volvulus will be in the clockwise direction. So reduction of the volvulus should be done in the anti-clockwise direction. Then after the reduction of the volvulus in the anti-clockwise direction, Latz bends should be divided, which originates from the cephalic tube, crosses above the duodenum, and attached to the lateral peritoneal wall, crossing the gallbladder. So the second step in the Latz procedure is the division of the Latz band. And the third step is the division of the mesenteric gland, which includes the widening of the mesenteric base. This step is much more important because if we doesn't widen the mesenteric base, the recurrence of volvulus will be more common. Then after the widening of the mesenteric base, small bowels are placed on the right side and the large bowel are placed to the left. Then appendicectomy should be done. So main steps in Latz is the reduction of the volvulus, division of the latch band, division of the mesenteric glands, that is the widening of the mesenteric base and straightening of the duodenum, and placement of small bowel to the right and large bowel to the left, and appendectomy should be done compulsory. So this is the pictorial representation showing the reduction of volvulus in an anti-clockwise direction, division of the latch band, and broadening of the mesentery. Sorry. So what are the complications of latch procedure? When there is the volvulus, sometimes when it goes for gangrene, we want to remove the gangrenous segment, which results in the short bowel syndrome. And the infection of the wound. The post-surgical complications include adhesive small bowel obstruction, recurrent volvulus when the base of the mesentery is not widened properly, resistant gastrointestinal symptoms which include constipation, intractable diarrhea, chronic abdominal pain, vomiting, and feeding difficulties. The next cause of intestinal obstruction is the necrotizing enterocolitis. This is the most common gastrointestinal surgical emergency in the neonatal period. So, necrotizing enteritis is the most common GI surgical emergency in newborn period. It is characterized by variable degrees of damage to the intestine, ranging from mucosal injury to the full thickness necrosis and the perforation. The most important etiological fracture is the prematurity and the prematurity of the bowel. Other factors are ischemia, bacteria, cytokines, and early enteral feeding in the premature child. The following are the risk factors, most common being the premature neonates, which is less than 34 weeks gestation, low birth weight less than 2.3 kg, starting of enteral formula feeding, or a difficult delivery which is resulting in the lower oxygen levels during labor. Or the child is on when the mechanical ventilation or umbilical vein catheterization are more prone for necrotizing enterocolitis. The child with PDA or child with infection with premature rupture of membranes or a patient treated with indomethacin are also prone for NEC. Or in case of exchange transmission or polycythemia, there will be a chance of necrotizing enterocolitis. But the most common persistent which is the prematurity of the bowel and enteral formula feeding. So the clinical features common mainly affects the terminal ileum and the proximal arsenic codon, but whole of the bowel can be affected. But most common location being the terminal ileum and the proximal arsenic colon. The classical clinical triad comprises abdominal distension, bloody stools, and the hematosis intestinality. The clinical features and the radiological features, with the help of clinical features, the neonatal enterocolitis are staged into three categories with the Bell staging system. So some non-specific symptoms such as vomiting, diarrhea, feeding intolerance may appear. Abdominal tenderness, abdominal wall edema or erythema or palpable loops are indicating the fixed and dilated loop may develop. In case of perforation and pneumoperitoneum, there will be the erythema and the tenderness of the abdominal wall. In some rare cases, the child may progress to the severe sepsis and may present with apnea, bradycardia, or level body temperature, hypoglycemia, and shock. So the classification of neonatal enterocolitis is based on Bell staging. Bell stage 1 is suspected necrotizing enterocolitis. That is stage 1A. Stage 1 is suspected. Stage 2 is definite. Stage 3 is advanced. So stage 1 is suspected NEC. In stage 1A, there will be the mild non-specific systemic signs such as apnea, bradycardia, and temperature instability. With the mild intestinal signs such as increased gastric residuals and mild abdominal distension. Radiographic findings can be normal and sometimes there will be the mild and non-specific distension. So in stage 1A of necrotizing enterocolitis, there will be only the mild non-specific systemic signs and mild intestinal signs such as gastric radials and mild abdominal distension. And more or less radiographic features will be normal or presence with dilatation of the bowel. Stage 1. In the stage 1A of the above features, when associated with a glossy bloody stool, it comes under stage 1B. In case of NEC, the bloody stools comes under stage 1B. So, well, stage 2. Stage 2 is the definitive disease. Stage 1 is suspected NEC, while stage 2 is definitive disease. Stage 3 is advanced disease. Stage 3 is again divided into A and B. Stage 2A, the patient will be mildly ill. Systemic signs will be present that of the 1A, but intestinal signs will present apart from that absent bowel sounds and abnormal tenderness. In type 1A, the bowel sounds will be normal, there will be no tenderness, but with mild dilated bowel loops and the absence bowel sounds and abdominal tenderness comes under stage 2A. Radiographic finding includes ileus or nematosis intestinalis. This is also a most important question. Nematosis intestinalis comes under stage 2A, which stage 2A of NEC. One of the prominent feature for the necrotic enterocolitis. So in stage 2B, the patient will be moderately ill. With that of the stage 1, it also there will be the metabolic acidosis and thrombocytopenia. Abdominal examination reveals definitive tenderness, erythema, or sometimes lower potent mass. Radiographic features shows the portal venous gas with or without ascites. So, portal venous gas comes under stage 2B. So, well, stage 3 is an advanced disease. In the stage 3A, the patient will have a severe NEC with an intact bowel. Diagnosis requires of that of the above features with that of the hypotension, bradycardia, respiratory failure, metabolic acidosis, coagulopathy, and neutropenia. Abdominal examination will show the distension with marked signs of generalized peritonitis. Radiographic definitive evidence of the ascites. So, with abdominal tenderness and signs of generalized peritonitis and signs of shock, with the radiological examination showing ascites comes under advanced stage of NEC, stage 3A. When the with the above features, when there is a perforation of the bowel, perforative peritonitis on a radiograph, or air column in the X-ray, it shows the stage 3B. So, NEC can be varied from simple abdominal distension with the fixed dilated loop up to the perforation of the bowel with various radiological features for the specific staging. So, the most commonly asked questions regarding to the specific staging are bloody stools will be present in the stage comes in the stage 1B, and the nematosis intestinal is present in the radiographic pictures comes under stage 2A, and the portal venous gas can be appreciated radiologically either by ultrasound or X-ray. It comes under stage 2B, and the presence of ascites comes under stage 3A, and the pneumoperitoneum or a perforative peritonitis comes under stage 3B. So the treatment varies according to the stages. So this is the X-ray picture showing the gas shadows in the wall of the bowel. That is the nematosis intestinalis. This is the presence of gas in the walls of the bowel. So this is the X-ray picture. A is showing the nematosis intestinalis. It is a pathognomic radiac scan for NEC. And the another picture is showing the in the lateral decubitus position, showing the free air in the abdomen. That is the pneumoperitoneum, which is comes under stage 3B. So the treatment first is the child should be kept in Ilperlower and the nasogastric decompression should be done. The electrolytes abnormality should be corrected, dehydration should be corrected, and the support for blood pressure should be done. And the TPN should be started early with NPO. And the antibiotic, broad spectrum antibiotic coverage should be done. The baby is rapidly deteriorating with apnea or signs of circulatory or respiratory failure. Mechanical ventilation may be needed. So, what are the indications for surgery in case of NEC? Mostly conservative treatment with assessing for the progress of the stages of the NEC with IV fluids, IV antibiotics. But stage 3B, that is perforative peritonitis or the pneumoperitoneum is an absolute indication for the surgery. Relative indications be weak in clinical, progressing erythema or clinical deterioration of the child with signs of peritonitis or hemodynamic instability. In case of radiological persistent pixel group, ascites and portal venous can be relative indication. In laboratory findings, when the positive paracentesis, that is 0.5 ml of brine that contains bacteria on gram staining or worsening or acidosis, or persistent thrombocytopenia or rising leukocytosis. These are the laboratory investigations, which are the relative indications for surgery. The complications. Coming to the complications of NSA due to perforation or in necrotizing enterocolitis, most common affected loop will be the terminal ileum and arsenic colon. But generally, whole of the small bowel or large bowel can be have the patchy necrosis. When the necrosis or involved segment is more, it can be resulting in the resection of the large segment of the bowel, resulting in the small or short bowel syndrome. Another complication is the intestinal structure. This is also one specific questions commonly asked in exams. That is the location of the intestinal structures in case of neonatal enterocolitis. The neonatal enterocolitis induced strictures are most common in the splenic flexure area. So then other complications of TPN can be there, such as the cholestasis or direct bulimia and long-term follow-up neurodevelopmental delay and the psychomotor retardation. So we have already seen atresia, NEC and malrotation with volvulus. The next common type of neonatal intestinal obstruction will be the meconium ileus. Meconium ileus is usually accounts for up to 30% of the neonatal small bowel obstruction. It is usually associated with cystic fibrosis, that is, it is an autosomal recessive disease. CFTR mutation, that is, cystic fibrosis transmembrane regulator gene. It results in the abnormal chloride transport, resulting in the tenacious viscous secretions within the thick insulated meconium, causing the obstruction. The protein concentration will be 80 to 90%. Other areas of, affecting in case of cystic fibrosis are intestine, pancreas, lungs, salivary glands, reproductive organs, and also biliary tract. Sometimes the first and early presentation of the cystic fibrosis will be that of the meconium ileus. So in each and every case of the meconium ileus, the child should be detailedly examined for CFTR and cystic fibrosis. Antenatally, there will be the maternal polyhydramnios in 20% of the cases. Postnatally, the abdominal radiograph shows dilated bowel loops with relatively absent air fluid levels. In all other cases of intestinal obstruction, there will be the proximal dilated loops with air fluid level. While in case of meconium ileus, the air fluid level will be much less due to thick insipated meconium, causing the soap bubble appearance in the right iliac fossa. The most common feature is the soap bubble appearance in the right iliac fossa. The contrast enema will be successful in 75% of the simple meconium ileus. It may be meconium ileus may be simple or complicated. In simple meconium ileus, contrast enema may be both diagnostic and therapeutic. In some cases, N-acetylcysteine orally or through the nasogastric tube will serve to relieve from the simple meconium ileus by the breaking the disulfide bond. The enema acts by hygroscopic action, withdrawing the fluid inside, causing thick inspiration to dilate, to diffuse, and pass out. While N-acetylcysteine, it serves the breakage of disulfide bonds present in the meconium. So, the clinical presentations will be the abdominal distension, failure to pass meconium, and bilious vomiting. It is of two types, simple meconium ileus, and there is only the thick insulated meconium obstructing the aroma of the ileum. In case of complicated meconium ileus, that is which in presence with volvulus, or bowel gangrene or perforation leading to the spillage of meconium into the peritoneal cavity, causing meconial peritonitis or pseudocyst formation, or resulting in intestinal atresia. These are the considered complicated meconium ileus. The investigations are fine abdominal radiograph, which shows dilated loops of the small bowel and the ground glass appearance. In case of complicated meconium ileus, that is the meconium ileus perforated and cause perforative peritonitis, there will be the curvilinear calcification when the rupture is present antenatally. So, when the X-ray shows curvilinear calcification in a suspected case of meconium ileus, you should think of antenatal perforation of the bowel with spillage of meconium leading to curvilinear calcification. The contrast enema will usually show the distal unused colon resulting in the microcolon, and sometimes it can be both diagnostic and therapeutic. And cystic fibrosis should be ruled out by doing pilocarpine enterococci test, that is, when the chloride concentration is higher than 60 milliequivalent per liter. So the treatment consists of non-operative and surgical. Non-operative gastrographin enemas can be referred. Gastrographin is a hyperosmolar aqueous solution which draws fluid to the bowel and loosens the meconium. So it is important to hydrate the child prior to the enema. And also the pancreatic deficiency, enzyme deficiency will be there. So pancreatic enzyme replacement should be done. In surgical, for the simple meconium ileus, the gastrographin enema or N-acetylcysteine is usually enough. In case of failed conservative treatment, in case of simple meconium ileus, a surgical approach should be considered. For the complicated meconium ileus, definitive is the surgery. The types of surgery are in simple meconium ileus failure to the medical treatment. An enterotomy after laparotomy, an enterotomy can be made in the distal ileum, and the Polish tube or feeding tube can be introduced, and it should be irrigated. Sometimes there would be a thick insufficient meconium with a proximal hugely dilated bowel. So the only dilated segment is resected and the inspected meconium is removed and the primary anastomosis is done. Sometimes there will be required for ileostomy, which is with the tube enterostomy. So through the tube, we can be irrigate the distal bowel. So this is the picture showing the distal unused colon and the proximal dilated with the thick inspected meconium. So post-operative management, even after the removal of the thick inspected meconium and primary anastomosis, 10% N-acetylcysteine can be given orally or injective or through the ileostomy if present. Then pancreatic enzyme replacement should be done. Prophylactic pulmonary therapy should also be indicated. So this is the pictorial representation of the distal unused colon. And a slow bubble appearance in the right ileum fossa with the thick inspected meconium. This is the picture showing the dilated proximal bowel proximal to the thick inspected meconium. So the enterotomy can be made or Foley's can be introduced and the irrigation of the distal bowel can be done with saline or N-acetylcysteine. So next cause of intestinal obstruction is the Nichols diagram. It follows the rule of 2. It is the most common congenital anomaly. Presence in 2% of the population, 2% there will be the ectopic gastric mucosa or pancreatic mucosa. 2% are symptomatic. It is 2 inch length and 2 feet from ileocecal walls. It is a true congenital diaphragm having all the layers of the bowel. 70% are being symptomatic when they have ectopic gastric mucosa, while in the symptomatic patient, 5% have the pancreatic tissue. Male is to female ratio of 3 to 5 to is to 1. So males are most commonly affected 3 to 5 times. What is the embryology of the Nichols diagram? During embryology or the growth of the child, omphalomycentric duct that connects the embryonic midgut to the yolk sac ventrally, providing the nutrition to the midgut during the embryonic development. This subsequently, the vital intact narrows progressively and it disappears between the 5th and 8th weeks. The failure in this disappearance or any abnormality results in the various anomalies. So the home flow enteric duct anomalies includes Michael's diverticulum, home flow mesenteric ligament or fibrous band, home flow mesenteric fistula, home flow mesenteric cyst, or persistent vitelline artery which runs along the fibrous cord, which connects the ileum to the umbilicus, causing obstruction or umbilical sinus. These are the various anomalies. So the symptoms. Usually, Michael's diverticulum is asymptomatic and non-incidental finding, but it becomes symptomatic only as a result of complications. The complications main being the painless rectal bleeding. A childhood painless rectal bleeding should be evaluated for the Michael's diverticulum, or sometimes it may cause diverticulitis with obstruction or intussusception or valvulus. So there is a most common that is, Michael's diverticulum is frequently suspected, often looked for, and seldom found. So it is a rare, only found asymptomatic, only found when the complication arises. So diagnosis can be done by technetium 99 PET thickness scan, then colonoscopy or angiography or capsule endoscopy. As technetium 99 PET thickness scans is valuable when there is the presence of extrinsic or ectopic gastric mucosa in the Michael's. The treatment is surgical excision, mainly of veg resection, or nowadays when there is the involvement of the base, the chances for malignancy or erosion is there in the base of the metal. So complete resection and primary anastomosis of the ileum is the preferred surgical treatment for metals. Then comes the Hirschsprung disease. What is Hirschsprung disease? It is a congenital megacolon or Hirschsprung disease. It is due to the absence of ganglionic cells in the myenteric and cervical plexus of the colon. Boys are most commonly affected. It occurs in 1 in 5,000 live births. Due to neurogenic parasympathetic abnormality, muscular spasm of the distal colon and internal sphincter leading to the functional obstruction. So rectosigmoid is the most commonly affected portions in the Hirschsprung disease in 80% of the cases. Then splenic or transverse colon is affected in 17% and the entire colon in 8% of the cases. So the classical Hirschsprung means is the rectosigmoid section. Rectosigmoid segment of the colon is most frequently affected. That is called the classic Hirschsprung disease. Or long segment Hirschsprung disease and the splenic or transverse colon involved, or total colonic agangliosis or TCA when the total colon is involved. Hirschsprung disease is usually associated in 3 to 5% with Down syndrome. So there will be the abnormal locus on the chromosome 10 in the reticulum. Infants present usually with the abdominal distension and bilious emesis with failure to pass meconium within the first 24 hours of life. Usually, the child passes meconium within first 24 hours of life, and there is non-passage of meconium after 24 hours of life, or delayed passage of meconium. Then, Hirschsprung disease should be suspected. In this case, the rectum will be wider more than the sigmoid colon. In the spasm of the distal rectum usually results in the narrow collector with a transition zone. That is, the normal upper bowel will be dilated and the aganglionic lower bowel will be narrowed. So, when the contrast is instilled, there will be the conical shape with the upper dilated portion, transition zone, and the lower narrowed portion. And also the failure to evacuate the instilled contrast even after 24 hours. So 24-hour delayed picture when X-ray is taken after the installment of the contrast. When there is a failure to evacuate, then it clearly indicates that Hirschsprung disease. Other causes of constipation such as meconium plug syndrome, small colon syndrome, and atresia should be ruled out. So manometric finding, which is important to find the differentiate the internal sphincter pressure and the rectum is distended. The gold standard technique to diagnose spine disease is the rectal biopsy. This is also a important question. That is the gold standard method to detect spine disease is the rectal biopsy, and in rectal biopsy you should show absence of ganglionic cells, hypertrophy neurons are the main indicating features. In the rectal biopsy in HPE, when there is the absence of ganglionic cells in the distal rectum and the hypertrophy neurons, it is the definitive of the spine disease. Some advanced staining techniques such as acetylcholine esterase or called rectal immunostaining are frequently used for rapid identification of the spine disease. Presenting features will be constipation, frequent soiling, incontinence, and post-operative enterocollitis will be there. So, this is the contrast edema showing the transition zone on the upper dilated bowel, which is the normal, and the lower constrictor bowel, which is that of the aganglonic segment. So, this is the preferred method of treatment is the diagnostic by first X-ray shows the dilated roof and the absent rectal gas shadow, and the barium or contrast enema showing upper dilated bowel with the transition zone and the lower constricted bowel are suspective of spine disease. Most definitive diagnostic method is the rectal biopsy, in which you should see the aganglonic lower segment with that of the hypertrophy nerve bundles. So after confirming the diagnosis, the treatment will be going for the proximal colostomy. That is at least 4 centimeter above the transition zone, the colostomy is done. Then further after 6 months, the rectum is pulled through down from the colostomy side. So the next cause of neonatal obstruction is the anorectal malformation. That is the absent anus at the proposed site. Normally the anus should be present between the midpoint between the two ischial spines. So absent anus in that position is called anorectal malformation. It occurs in 1 in 5,000 eyebirds, and the eyes are most frequently affected. Usually, hemorrhage being the during 6th week of gestation, this urorectal septum moves caudally to divide the cloaca into the anterior and posterior parts. The anterior part developing into the urogenital sinus, while the posterior part developing into the anorectal canal. So, during the 6th week of gestation, this urorectal septum moves caudally into the cloaca to divide into anterior urogenital sinus and the posterior anorectal canal. So, when there is a complete or partial failure of this anal membrane to be reabsorbed, it will result in the anal membrane or the stenosis. So, perineal body results from the fusion of the cloacal folds between the anal and urogenital membrane. So, anorectal anomaly is divided into anatomical classification at the level at which the blind ending rectal functions into the low, intermediate, or high in relation to the levator anal musculature. So, anatomical classification of anorectal is divided into low, intermediate, and high. Most common associated anomaly is renal anomaly, which is associated with the security reflex and hydronephrosis. When there is a persistent cloaca or only the single opening in the female child or rectovesical fistula, 90% is associated with the genitourinary abnormality. So, renal ultrasound should be done to rule out any renal anomaly, and micturating cystourethography or voiding cystourethography should be done to rule out reflexes in these children. So, the clinical features first, after delivery, you should see the sex of the child, whether it is male or female child. In males, more high anomalies are more common, while in females, low anomalies are more common. Then the buttocks should be inspected for the formation of the muscle bulb or the flat buttocks. And the perineal signs, that is the any presence of meconium at the perineum or some absent anal opening with meconium staining in the perineum will indicate of the anocutaneous fistula. Or the bucket handle malformation should be inspected on the anal membrane through which the meconium is visible. When the meconium is seen at the perineum or the buccal handle malformation or anal membrane seen, it all three indicates low anorectal anomaly. The abdominal distension will be present. In some cases, the diaper should be inspected to check for the staining of the meconium while passing urine. When there is a fistulous connection between the distal abnormal bowel to the bladder or to the urethra, there will be the meconiuria. Usually, anorectal anomaly is associated with fistulous connection to the bladder or the urethra. And there is the connection to the bladder or urethra, there will be the meconiuria. Meconiuria indicates the high anorectal anomaly. So, while inspecting the male cell, this is the flat buttocks showing the absent anal canal in the proposal site, with no staining of the perineum. So, this is the absent anal opening in the proposal site with a small pit proximal to the proposal site and small staining of meconium is present. So, when the meconium stain is present in the perineum, it comes under low anorectal anomaly. So, this is the bucket handle deformity. That is the normal anal opening will be there. Above that, a stand of skin is placed over and it is closed. We can hook out and we can. It is called bucket handle deformity. It comes under low anorectal anomaly. So, when there is a meconium staining in the perineum or bucket handle deformity or anal membrane is present, it comes under low anorectal anomaly. If meconiuria is present, it comes under high anorectal anomaly. Another one is this is called meconium pearls. That is staining of meconium in the midline rapid. It can extend from the proposite of anus, sometimes even up to the penis in the midline. So, the presence of meconium pearls is an indicator of low anorectal anomaly. So, and there is a meconium pearls or meconium staining in the perineum or bucket handle deformity or anal membrane. This all four indicates that it is the low type anorectal anomaly. If meconiuria is present, it is high type anorectal anomaly. So, when coming to a female, we should inspect for the number of openings in the perineum. Usually, in anorectal anomaly, there will be the absent anus at the proposite site, and then you should look for the number of openings. That is the normal urethral opening, vaginal opening, and any other opening. There will be the normal urethral and vaginal opening, and below the vagina there will be a single opening, fistulous opening through which the fecal material or meconium comes out. So it is the anovestibular fistula. The most common anomaly in the female anorectal anomaly is the anovestibular fistula. It is of the low type. The investigations done for anorectal anomaly is cross-table lateral prone X-ray. That is, the child is placed in the prone position and the X-ray beam is focused in the lateral so that the single femur is visible to assess the level of the bowel to the distance between the perineum and the column of air in the abdomen. When the column of air in the distal rectum is within the 1 centimeter of the perineum, it is called low anorectal anomaly. If it is more than 1 centimeter of the perineum, it is called a high anorectal anomaly. Cross-table lateral prone X-ray should be done only after 18 to 24 hours after birth. It is also an important question. That is, when should be cross-table prone X-ray should be done? It is 18 to 24 hours after birth. So this is the picture showing cross-table lateral prone X-ray with the contrast coin placed in the perineum, and you should see the distance between the distal rectal shadow and that of the perineum. If it is less than 1 centimeter, it is low anomaly. and it is more than 1 centimeter, it is classified as high anorectal anomaly. In plain radiography, you should see look for the abdomen, distance of the bowel, and you also should look for the spine. In case of high anorectal anomaly, it also associated with rectal anomalies and spinal anomalies with the loss of the vertebral levels. When the loss of the vertebral levels is more than 2, that is sacral vertebra, there will be the loss of sacral vertebra, and if it is more than 2, then the continence of the child will be in questions. It will be incontinent. Ultrasonography should be done to rule out other spinal and renal anomalies. Then, after the initially in high anorectal anomaly, colostomy should be done. After colostomy, before definitive procedure, distal cologram should be done to look for the length of the distal bowel before pull through. So, in the newborn period, in case of low anomaly, anaplasty is done as a single stage. In case of high anomaly, it should be done under 3 stages. First, initially, colostomy is done. Then, after 3 to 4 months, distal colostomy or distal cologram should be done to look for the length of the distal bowel from the colostomy site and to the look for any reflux into the urinary system. So, distal cologram and micturating cystourethrogram should be done before the definitive procedure. So, this is the distal cologram picture showing the distal colon filled with contrast material, and there is a fistulous connection to the urethra, and this is the fistulous connection to the bladder. So, this is recto-urethral fistula. This is the rectovesical fistula. So, the classification of anorectal anomalies. It is classified independent of the male and female. In female, it is classified as cutaneous or perineal fistula, then anovestibular fistula, imperforate anus without fistula, rectal atresia, cloaca. In cloaca, there will be only the single opening, that is urethra, vagina, and the anal openings joins into and forms a common cavity, and there will be only the single opening, which both three of the canal entering into the single cavity, and the complex malformation. While in case of male, cutaneous or perineal fistula, rectourethral fistula, bulbar or prostatic fistula is there, or rectal broadal neck fistula will be there, or rectal atresia, imperfect anus fistula. These are the classifications. While cutaneous fistula and vestibular fistula comes under low anorectal anomaly, cloacal or rectobulbar or prostatic fistula comes under high anorectal anomaly. Then comes to the management. Initially, for low anorectal anomalies, anaplasty is done. For high anorectal anomalies, descending colon colostomy with double bladder colostomy should be done. In case of male newborns, in case of rectoperineal fistula, anaplasty is done. While for rectobulbar or rectoprostatic or bladder neck fistula or rectal atresia, colostomy is initially done, followed by rectal pull through, and then followed by colostomy closure. So, for low anorectal anomaly, single stage anaplasty is done in male cell. For high anorectal anomalies, initially colostomy should be done, then distal cologram and micturating cystourethrogram should be done to know about the distal length of the bowel and fistulous tract if any present. Then followed by definitive procedure. Then in the third stage, colostomy reversal should be done. For female newborns, in case of rectoperineal fistula or rectovestibular fistula or anovestibular fistula, anoplasty is done. In case of imperforate anus without fistula or rectovaginal fistula or cloaca, first initially colostomy is done, then detailed examination of the distal communication is done, then definitive procedure, then third stage colostomy reversal. So, this is the male cell, this is the triangular anoplasty. That is for low anorectal malformation in the male cell. Triangular anoplasty is done for low anorectal anomalies. For high anorectal anomalies, this divided colostomy is done in the descending colon. So, after doing the colostomy, definitive repair should be done. It may be the posterior sagittal approach. That is, child is placed in the posterior position with surgical incision is done and the bowel is brought down to the original position and the reconstruction of the muscular complex system. A distal colostogram showing the terminal end of the bowel extending below the second sacrovertebra indicates that the posterior surgical anorexia can be performed. So, coming to the anorectal malformation in a newborn male, first initially a perineal inspection should be done to classify as low anorectal anomaly or high anorectal anomaly. In case of any meconium staining in the perineum, bucket handle deformity, anal membrane, it is classified as low anorectal anomaly, or meconiuria presence or in lateral cross table prone X-ray. And the distance between the perineum and the distal rectum is more than 1 centimeter. It comes under high anorectal anomaly. Before proceeding, bacterial anomaly should be ruled out. So, ultrasound spine and the kidney and sacrum should be done to rule out any renal and spinal anomalies. Then, urine analysis should be done to rule out urosepsis. And TEF should be ruled out. That is, investigation should be done to rule out bacterial anomalies. Then re-evaluation should be done if there is a perineal fistula, anoplasty, or if it is the intermediate or high fistula, colostomy should be done. Then definitive procedures are done at later periods. While in case of female anorectal anomaly, after ruling out potential associated defects, perineal inspection is done. If it is for perineal fistula or vestibular fistula, anoplasty should be done initially. If the perineal orifice is single, that is the presence of cloaca or no visible fistula, or the recto-vaginal fistula, initially colostomy should be done, followed by definitive procedures. So that's all finishing that of the neonatal intestinal obstructions. Neonatal intestinal obstruction, the most common being the atresia, followed by malrotation of the volvulus, followed by meconium ileus. Then other causes are Hirschsprung disease, anorectal anomalies, meconium ileus, meconium plug syndrome, small left colon syndrome, others. Then next topic is cryptorchidism. What is cryptorchidism? Or undescended testis? Failure of normally testis descends from its original position. Testis descends from its original position to the scrotum. By 7th month, it is present at the deep ring. 7 to 9 months, it transfers the inguinal canal, and by the end of the 9th month or before delivery, the testis should be in the scrotum. So, the passage is 7 months at the deep ring, 7 to 9 months in the inguinal canal. In the 9th month or before delivery, the testis should be reach the scrotum. It is the normal path of descent. What is the difference between ectopic testis and the undescended testis? When the testis is located in the path of the descent anywhere, it is called undescended testis. If the testis is located apart from this path of the descent, it is called undescended testis or cryptorchidism. Most common affected are, it is most commonly 30% in the 30% of the affected individuals are the preterm individuals and 3% in the full-term infants. Before 6 months of age, there will be the histologic and morphological changes at the 6 months of age, leading to the atrophy of the Leydig cells, decrease in the tubular diameter, and impaired perimucogenesis, which occurs by 2 years of age. So, as early as possible, at 6 months of age, the correction should be started. Does orchiopexy reduce the risk of malignancy? No, orchiopexy does not reduce the risk of malignancy. It only helps to examine yearly when there is the development of malignancy. So, what are the factors affecting the descent of the testis are responsible for the cryptorchidism? One is main is prematurity, low birth weight, diabetes and obesity in the mother, alcohol consumption during pregnancy, cigarette smoking, family history of undescended testes, or when parents exposed to some pesticides, or in affected individuals with some symptoms that is Down syndrome, Prader-Willi syndrome, and Mann syndrome. These are the factors affecting the or causing the cryptorganism. Usually, undescended testes are also associated with reduced fertility, increased risk of germ cell tumors, psychological problems at the time of puberty, and more susceptible to testicular torsion and infarction, and it also associated with inguinal hernias. So coming to the embryology, testis develops from the primordial germ cells to form testicular pulse along the genital ridge in the abdomen, which is under the influence of SRY gene. So SRY gene stimulates the testis to develop primordial germ cells to form testicular pulse along the genital ridge of the embryo. The cells in this testis further differentiate into Leydig cells and Sertoli cells. These Leydig cells are testosterone producing cells, and the Sertoli cells are Mullerian inhibitor hormone producing cells. This occurs during the 3rd to 5th month of intrauterine life, and the germ cells become fetal spermatogonia. So the male external genitalia develop during the 3rd and 4th months of gestation. These testes remain high in the abdomen until the 7th month, when they move from abdomen through the inguinal canal and then into the scrotum. So this movement of the testes occurs in mainly 2 phases. In the first phase, there is the movement of testes across the abdomen to the entrance of the inguinal canal, which is mainly influenced by the anterior Mullerian hormone, which causes regression of the Mullerian structures such as uterus and fallopian. In the second phase, the movement of the testes is through the inguinal canal into the scrotum. It is influenced mainly by the testosterone. So the testis that is absent from the normal position can be undescended testis, which is non-palpable undescended, or palpable undescended testis that is in the inguinal canal. The most common location of the undescended testis is the superficial inguinal folds, or it can be in the ectopic sites such as perineum, the thigh, or suprapubic region, or it may be underdeveloped, or hypoplastic, or severe, or dystinctic, or it can be vanished into bottom, that is anarchia. These are the abnormal position of the testis in the scrotum. It may be the undescended, non-palpable, undescended, palpable along the descent, or ectopic, or underdeveloped, or vanished. So, what is the treatment? The treatment being the when case of unilateral non-palpable undescended testis, or all cases of non-palpable testis, the ultrasound or MRI has the low sensitivity to detect the testis from differentiate from the node. So diagnostic laparoscopy is the preferred method of diagnosing for non-palpable undescended testis. In case of non-palpable undescended, diagnostic laparoscopy is done. Then if the vessels are blind ending, then it is considered as anarchia or monarchia, or if some remnants are present, you should excise the remnant. If the vessels are seen exciting the internal link, then the testis will be in the inguinal canal. So inguinal approach is exploration is done. And if the testis is viable and of full development, archaeopexy can be done. If it is found to be nubbing in the inguinal exploration, then archaectomy is done. Sometimes even in the intra-abdominal position, the testis is found to be nubbing. In that case, archaectomy is done. In some case, the testis is very fully developed, but in the intra-abdominal position, which cannot be brought down in a single stage. So, in that cases, the Fowler-Stephens archaeopexy is done. What is Fowler-Stephens archaeopexy? The main hindrance for the bringing down of the testis to the scrotum is the testicular vessels. So, initially, the testicular vessels is divided proximally. Then, how the testis can receive its blood supply? The collateral supplies from the vas, vessels to the vas and cremastic vessels and the pulmonary vessels. The collaterals develops and it supply the testis. So after 6 months, this peritoneal pad along with this collateral vessels is mobilized and the testis is brought down. So dividing of the dividing of the testicular vessels, allowing the to form collateral vessels, then bringing the testis to the down to the scrotum is called Holder-Stephens archaeopexy. So that is at 6 months of age, testicular vessels are divided as stage 1, and in stage 2, after 6 months, allowing adequate time for the collaterals to develop. At the 1 year of age, the testis is brought down to the scrotum. So, by the rule, the testis should be present in the scrotum by before first birthday, by 1 year of age. In case of palpable undescended testis, open archaeopexy is done at 6 months of age. In case of bilateral non-palpable testis, SCG stimulation test is done. When there is the no response, it is considered synarchia. And there is the increased FSH and LH and testosterone, then laparoscopic exploration is done. Sorry. Then next coming to the topic of testicular torsion. What is testicular torsion? Testicular torsion, there are two types of the testicular torsion, extravaginal and intravaginal torsion. Extravaginal torsion is the most common in the neonates. That is the torsion of the spermatic cord along with the tunica vaginalis. In the neonates, the tunica vaginalis is not strongly adherent to the daughters. So, in the neonate, torsion of the spermatic cord along with the tunica vaginalis happen, then it is called extravaginal torsion. In intravaginal torsion, there is the bell clapper deformity. That is the long length of the testicular cord, that is the spermatic cord, leading to the torsion. It most frequently in the early adolescence, that is peak incident at the 14 years of age. So, how will the present of the testicular torsion? It may be present as an acute onset of the severe scrotal pain, the scrotal swelling and erythema, also associated with nausea and vomiting, local scrotal redness and pain. What is Prince saying? In case of acute testicular swelling, when you elevate the testis on the scrotum, if the pain is relieved, then it may be due to the epidermoarthritis. But even after the elevation of the scrotum, the pain is not relieved. It is called maybe probably due to testicular torsion. The most specific diagnostic test, but also not available at all the centers. But the most specific diagnostic test is the radioisotope scanning for the testicular torsion. So that is the picture showing the testicular torsion. That is the high riding of the testis with interpreted showing the torsion of the testicular vessels and gangrene of the testis. So the treatment is the detorsion of the testis with salvage. The salvage rate mainly depends on the time between the onset of symptom and the detorsion. So if you present as early total exploration, then the salvage rate will be more. It is between 19 and 100% the salvage rate when the detorsion is done within 6 hours of the onset of symptom. Between 20 to 40% after 12 hours. After 24 hours, only 10% can be salvaged. More than 90% will go for archaectomy or gangrene. So the salvage rate depends mainly on the surgical intervention or scrotal exploration between the onset of symptoms and your surgical timing. So once you diagnose acute scrotum as early as possible, scrotal exploration will be done to avoid gangrene of the testis. So the next topic will be on the tumors in the neonate or tumors in the pediatric age group. We can continue after 10 minutes break the tumors of the neonate. Thank you. So the sessions will be started again after 10 minutes break. That is the tumors in the pediatric. Thank you. Is the slide changing?
Yeah, it's changing. We can start.
Okay. Then it is the extrahepatic biliary atresia. It is also known as progressive obliterative cholangiopathy. It causes a progressive damage of the extrahepatic and intrahepatic bile ducts with cholestasis as a result of obstructive cholangiopathy secondary to the inflammation, which in turn leading to the fibrosis. And if not recognized and treated early, it leads to biliary cirrhosis and the liver failure. The most common cause of surgical jaundice in the infants is the extrahepatic biliary atresia. In extrahepatic biliary atresia, at the time of birth, the child will be present normal. Then progressively, while the age progress or the weeks progress, there will be progressive obliterative cholangiopathy, resulting in inflammation and fibrosis. So the incidence is variable and ranges from 1:10,000 to 15,000 live births. Girls are affected slightly more than that of the boys, and it is more common among Japanese and Chinese population. Biliary atresia should be considered in all neonates with direct hyperbilirubinemia, that is conjugated hyperbilirubinemia. So the etiology of biliary atresia, where there are various theories. Main is the reovirus 3 infection and congenital malformation and congenital cytomegalovirus infection, autoimmunity. The main is the identification and active and progressive inflammation and destruction of biliary system. Suspects the extrahepatic biliary atresia refers to acquired lesions. Infectious agents seem to be the most possible cause. Various proposed theories are congenital malformations, CMA infection, reovirus infection, and autoimmunity. But the most recent study is the infectious agent causing the acquired progressive inflammation. So, biliary atresia is classified into three types based upon the involvement of the common bile duct. Type 1 is the atresia involving the only the common bile duct, that is the proximal bile ducts are patent, while in type 2 the atresia is involving the common hepatic duct. This is usually associated with cystic structure at the porta hepatic. It is again classified into type 2A and 2B. Type 2A is the cystic and common bile ducts are patent. In type 2B, cystic, common bile duct and hepatic ducts all are obliterated. So type 1 atresia is the common bile duct atresia, while the proximal bile ducts are patterned. In type 2A, common and cystic bile ducts are patterned. And type 2B, cystic, common bile duct and have all are obliterated. In type 3 atresia, it involves the right and the left hepatic duct up to the portahepatics. So type 3 atresia is the most common type, more than 90% of the cases involving the right and left hepatic duct from the portahepatics, common hepatic duct, common bile duct, and gallbladder. So the most common type of biliary atresia is the type 3 atresia, accounting for more than 90% of the cases. So this is the picture one showing the atresia of the only the common bile duct or the common hepatic duct and the left are patterned. Type 2A only common hepatic duct is obliterated, while that of the hepatic duct and bile duct are normal. In type 2B, only right and left are patterned. All other common hepatic duct, cystic duct, and CBD are all are obliterated. In type 3, complete obliteration of the all of the ducts. So clinically, the biliary atresia occurs in two distinct forms. That is, fetal embryonic form and the postnatal form. The postnatal form is the more common. In the fetal embryonic form, it appears in the first 2 weeks of life. That is, about 10 to 20% of the affected neonates have associated congenital defects. The postnatal form appears in neonates and infants aged 2 to 8 weeks. It is involves the progressive inflammation and obliteration of the extrahepatic bile duct occurs after birth. It is not associated with congenital anomalies. Infants may have a short jaundice-free interval. That is, from 1 to 2 weeks, there will be no jaundice. Then further progressive jaundice develops. So, associated anomalies in case of biliary atresia are cardiac malformation, situs inversus, polysphenia, absent minor cava, or pre-renal portal vein, or bilobed systemic or symmetric liver, malrotation, and bilobed lungs. These are the most common associated anomalies. That is polysphenia, situs inversus, bilobed lung and liver, pre-renal portal vein, and malrotation. This is the cirrhotic liver in case of biliary atresia. The clinical features, the symptoms are seen usually between 1 and 6 weeks of life. The jaundice, which is prolonged and associated with clinical features of obstructive jaundice, that is prolonged jaundice, clay color stools, and dark color urine. In initial cases, hepatomegaly may be present early and the liver is often prone to hard on palpation. When the splenomegaly is present, it suggests the liver cell failure with progressive cirrhosis and total hypertension. So the investigations being the serum bilirubin, it shows the conjugated hyperbilirubinemia, alkaline phosphatate and gamma glutamate can be done. Serum aminotransferase serobites are done. The main thing is the marked elevated of alanine aminotransferase levels. That is more than 800 will be in more favor of neonatal hepatitis. In biliary atresia, it will be only mildly elevated, and there is a marked elevation of the alanine transferase level, that is more than 800 is more in favor of neonatal hepatitis. In case of congenital hyperbilirubinemia, neonatal hepatitis and biliary atresia should be differentiated. Then other investigations are serum alpha-1 antitrypsin deficiency and sweat chloride test. These are to rule out antitrypsin deficiency and cystic fibrosis. So then comes the ultrasonography. Ultrasonography is in ultrasonography there is the absence of the gland bladder and there will be no dilatation of the biliary tree. If there is the presence of or dilated gallbladder or dilatation of intrahepatic biliary tree, biliary atresia is ruled out. So it is also useful only in excluding the other causes, mainly polydopal cyst. The main investigations is the hepatobiliary isotope scan. When the dye is injected into the biliary system or in the gallbladder, when there is a intestinal extraction of this isotope confers the patency of the extrahepatic bile duct. So before this hepatobiliary isotope scan, the use of phenobarbital, that is 5 to 10 milligram per kilogram per day for about 5 days prior to the test is used. So it is an enzyme inducer to activate the presence of, to activate the enzyme, transferase enzyme. So when there is the intestinal extraction of isotopes into the extrahepatic bile duct, it confirms the patency and it rules out biliary atresia. Another important test can be done bedside is duodenal intubation. That is when the NG tube is intubated into the duodenum and there is the secretion of bile, it rules out completely biliary atresia. So this is the hydrogen showing the secretion of the turns into the duodenum. Then other diagnostic approaches are intraoperative cholangiography. During intraoperative approach, when there is the absence of gallbladder or atretic gallbladder, it finds out biliary atresia. Some or hypoplastic gallbladder is present. Yeah, when flown or feeding tube is cannulated to the gallbladder and the dye is injected. When the dye passes through the duct into the duodenum, then biliary atresia is ruled out. But when if the dye is injected and there is no traces of dye into the duodenum, we should clamp the distal CPD and again you should inject the dye to look for the proximal ducts. In case of biliary atresia, even proximal duct also will not be visible. So it confirms the diagnosis. The most definitive diagnostic method to prove biliary atresia is the liver biopsy. So liver biopsy is the gold standard technique to prove biliary atresia. It is the picture of the perioperative cholangiogram showing the feeding tube is introduced into the gallbladder and the dye is injected, and when the contrast is free flow of contrast into the duodenum is present, is rule out biliary atresia. So treatment based on intraoperative cholangiogram. Once the biliary atresia is confirmed, the atretic common hepatic duct up to the porta hepatis, bile duct and cystic duct and gallbladder are removed in tato, and the hepato or portoenterostomy is done. That is, jejunum is anastomosed into the porta hepatis. That is called precise portoenterostomy. But even though precise portoenterostomy is done, it is only a temporary intermediate procedure. Finally, all children will require liver transplantation. This is the perioperative cholangiogram with the dye injecting into the gallbladder. This is the is dissected up to the porta hepatis and the jejunum is anastomoted to the porta hepatis. That is portoenterostomy. Post-operative care. After the surgery, 1/3 of the patients will have drainage of bile into the duodenum and the jaundice will disappear. In remaining 1/3, initially there will be the decrease in the jaundice, that is the bile entry into the, then progressively due to progressive cirrhosis and inflammation, further again the child develops bilirubemia. It is intermediate. In less than 1/3 of the children in complete biliary atresia, there will be no passage of bile into the duodenum even after the portoenterostomy. So in that cases, immediate liver transplantation is the definitive procedure. So following portoenterostomy, what are the post-operative care we should be done? There will be reflex of duodenal contents into the enterostomy resulting in severe infection. So high dose pulse therapy with methylprednisolone or low dose can be used as both anti-inflammatory agent. Then for the effective drainage of bile, ursodeoxycholic acid can be added and prophylaxis with cotrimoxazole, that is trimethoprim, can be done to prevent cholangitis postoperatively. What are the postoperative complications in case of portoenterostomy? For precise, the 60 to 80% of the patients drain bile following. The following factors are shown to predict a long-term outcome. That is, when the age is younger than 2 months, or the preoperative liver histology and ductal remnant size is small, when the presence of bile in the hepatic lobular zone 1, absence of portal hypertension and liver cirrhosis, or post-operative decline and disappearance of jaundice. If these 5 factors are present, their prognosis will be good. When the age of diagnosis is more than 3 months, or if the ductal remnant size is very small, or when there is liver cirrhosis or portal hypertension, the prognosis will be very poor, and eventually the child will require liver transplantation. About 80% of the patients fail to have adequate bile flow following surgery. Only 50% of the child will develop cholangitis. Stricture can be present. There is a rare risk in the cells for the hepatocellular carcinoma. Liver transplantation is the only option for long-term survival in majority of the patients with biliary atresia. So, definitive investigation to confirm biliary atresia is the liver biopsy, and the precise photoenterostomy is only a temporary procedure. Definitive procedure is the liver transplantation in many of the cases with biliary atresia. So, next topic is the choledochal cyst. Choledochal cyst is the cystic dilatation of the biliary tract. The incidence is 1 in 1 lakh to 1 in 1 lakh 50,000. 60% are diagnosed before the age of 10 years. The male to female ratio is 1:4, or it be females are more commonly affected than males. Coming to the etiology, various theories have been proposed. One is the congenital malformation. Another one is the weakness of the wall of the bile duct leading to its dilatation. Another one is the obstruction of the distal common bile duct. But the most common acceptable theory is the common channel, that is a reflux of pancreatic enzymes into the common bile duct as a result of anomaly of the pancreatico-biliary junction. That is, due to anomaly of the pancreatico-biliary junction, there is the more common channel. So there is the more chance of reflux of pancreatic enzymes into the distal bile duct, leading to the dilatation of the bile duct. So coming to the classification, is classified into Totanist classification, classified into 5 types. Type 1 is the most common variety, 80 to 90%. In type 1, there are 3 variants, A, B, and C. In type 1A, there is a fusiform dilatation of the entire extrahepatic bile duct. In 1B, fusiform dilatation of the segment of the extrahepatic bile duct. Where 1C, fusiform dilatation of the CBD portion of only the CBD portion of the extrahepatic bile duct. So, type 1 is the most common variety. It is a fusiform dilatation. In type A, it is entire extrahepatic bile duct. In 1B, only the segment of the extrahepatic bile duct. In 1C, only the CBD portion of the extrahepatic bile duct. Or type 2, type 2 is an isolated diverticulum protruding from the CBD. This compromises only 5% of the types of choledochosis. Type 2 is an isolated diverticulum. Type 3 or choledochosis is the cystic dilatation of the intraduodenal portion of the CBD. While the intraduodenal portion is cystic dilatation, it comes under type 3 or choledochosis. In type 4, it has both A and B. In type A, it is characterized by multiple dilatation of both intrahepatic and extrahepatic biliarity, while type 4 is only multiple dilatation involving the extrahepatic bile duct. Type 5 or Coriolis disease is the cystic dilatation of the intrahepatic biliary ducts. Another form is called formifrustate of the choledochosis. What is formifrustate? Formifrustate is anything that is started to develop but is stopped in between. That is called formifrustate. What is formifrustate choledochosis? That is the cystic dilatation of the common duct is minimal or absent, but there is a long pancreatico-biliary union, partial obstruction of the lower common bile duct, and histopathological changes identical to the choledochosis in the world. That is, formifrustate choledochosis tends to appear, but there is an interference and it stops in between. There is a cystic dilatation is very minimal or absent, but there will be the long pancreatico-biliary union and histopathology similar to the choledochosis. So these are the different types of the type 1 is fusiform dilatation. Type 2 is only the diverticular dilatation of the CBD. Type 3 is intraduodenal dilated cystic dilatation of the common bile duct. Type 4A is both intra and extrahepatic multiple dilatations. 4B is only extrahepatic. Type 5 is only intrahepatic cystic dilatation of the milk. Coming to the clinical features, the classic triad of the choledochal cyst is abdominal pain, jaundice, and the abdominal mass. The infants commonly presents with elevated conjugated hyperbilirubinemia, that is in more than 80% of the cases, abdominal mass in 30% of the cases, and a failure to thrive. In patients older than 2 years of age, abdominal pain is the most common presenting symptom. While in infants, there will be elevated conjugated bilirubin. But while in patients older than 2 years, abdominal pain is the most common presenting symptom associated with intermittent jaundice, recurrent cholangitis, and pancreatitis. So the most common complications are cholangitis, pancreatitis, biliary cirrhosis, liver abscess, portal hypertension, and malignant degeneration. These are the main complications. This risk of complication increases with age, and the most important complication is the malignant degeneration. The incidence of 2.5 to 2.6%, 2.5 to 26%. So the diagnosis is made by ultrasound CT, and in some cases, for such as type 3 endoscopic graded cholangiopancreatography can be needed. Percutaneous transhepatic cholangiography and HID, that is hepatobiliary immunodiazolic acid scan, HIDA scan can be done. MRCP will be helpful in diagnosing and dealing in the anomalous and the length of the pancreatic biliary junction. This is the CT film showing the cystic dilatation of the CBD. This is the HIDA scan showing the dilated cystic dilatation of the CBD. This is the MRCP picture showing the distended gallbladder, cystic dilatation of the CBD, intrahepatic. This upper is the right and left hepatic duct. This is the uniform dilatation of the CBD. This is the gallbladder, and the dye draining into the duodenum. So the treatment varies. The primary is the complete excision of the disc. Primary treatment is the complete surgical excision of the cyst. It varies according to the type of the choledochal cyst. For type 1 cyst, it is treated with total surgical excision with the Roux-en-Y hepaticogynostomy. In some cases, the posterior wall of the cyst is closely adherent to the portal vein. So, in that case, it is difficult to completely remove the total cyst. So, Lilly's procedure is performed. What is Lilly's procedure? Lilly's procedure is the procedure where, in case, excising the cyst from within. That is, the cyst is open and the cyst wall is excised from inside, leaving the fibroposterior wall behind, which is adherent to the portal vein. Type 2 is treated with simple cyst excision. That is, the CBD should be closed transversely over a tube to avoid stricture formation. Type 3 is treated with endoscopic sphincterotomy if small in size. Otherwise, it should be excised via transverse duodenectomy. Type 4 and type 5 requires a complex procedure. Type 4 requires complete resection of the extrahepatic biliary tree whenever possible. Regarding intrahepatic ducts, surgery should be individualized depending upon the number of lobes affected, presence of stricture, presence of malignancy or cirrhosis. If intrahepatic cysts are localized into one lobe, hepatic lobectomy can be preferred approach. For diffuse intrahepatic disease, transplantation is the only considerable approach. Type 3, that is only cystic intrahepatic dilatation of the intrahepatic ducts, that is the Carolus disease. If it is unilateral or segmental with the cirrhosis, then resection of the involved part of the liver is sufficient and it is a treatment outside. In case of absence of cirrhosis or malignancy, hepaticogynostomy with bilateral transhepatic elastic stents may be indicated to improve the biliary drainage. The stents can be left for about 6 to 12 months. In cases especially with Carolus disease and liver failure, liver transplantation is mandatory. There are some complications post-operatively. That is, after accessing the choledochal cyst and Roux-en-Y anastomosis or anastomosis with the jejunum, there may be presence with cholangitis or biliary stone formation, anastomotic stricture, residual debris or biliary stone formation, pancreatitis, or intrahepatic bile ductal restriction can occur. So, coming to the tumors of the pediatric, most common tumor of the infancy or most common extracranial solid tumor in infants is neuroblastoma. Neuroblastoma is the most common extracranial solid tumor in infants and children. It accounts for 50% of the all cancer-related deaths. 90% have being diagnosed before the age of 5 years. In that, 30% within the first year of life. The median age of the diagnosis for the neuroblastoma is 22. Neuroblastoma is one of the component of the very small blue round cell tumor, and it is a malignant embryonal tumor arising from the sympathetic nervous system from the neural crest derived neuroblast. Wherever the neural crest cells are present, that is the sympathetic nervous system or adrenal medulla, from the neuroblastoma can develop. It is one of the small blue round cell tumors. And the other small blue round cell tumors are Ewing sarcoma, non-Hodgkin's lymphoma, primitive neuroectodermal tumors, and rhabdomyosarcoma. It may be one of the entrance questions. Which of the following is not comes under small blue round cell tumors? So, small blue round cell tumors are neuroblastoma, Ewing sarcoma, non-Hodgkin's lymphoma, PNET tumors, that is primitive neuroectodermal tumors, and rhabdomyosarcoma. These are the some of the small blue round cell tumors. So 65% of the neuroblastomas are usually found in the abdomen, with 50% localized to the adrenal medulla. And others may be present in the neck, chest, or the pelvis. In rare cases, in 1% of the individuals, it may be the occult primary, only secondary will be visualized. A diagnosed neuroblastoma is a very aggressive tumor. A diagnosis 50% of the patients have localized disease and 35% have regional lymph node. What are the symptoms? It presents symptoms according to the location. While in the abdomen, it causes abdominal fullness and distension. Children with localized disease are usually asymptomatic, whereas in most cases, they present with a disseminated neuroblastoma. Usually, the child will look sick and may have systemic manifestation like weight loss, anorexia, failure to thrive, fever, and bone pain. So, in case of Wilms tumor, the child will be good looking, healthy, and then incidentally findable mass. While in case of neuroblastoma, the child will be generally sick and may have systemic manifestations like weight loss, anorexia, failure to thrive, bone pain, etc. So the most common finding with abdominal neuroblastoma is a non-tender firm irregular abdominal mass that crosses the midline. While that of the Wilms tumor, it is also a intra-abdominal neoplasm, but it does not cross the midline. While in neuroblastoma, it is a non-tender form irregular abdominal mass that crosses the midline. Some of the syndromes associated with the neuroblastoma. The one is the Kerner-Morrison syndrome or VAPOMA. That is, it is caused by vasoactive intestinal polypeptide tumor secretion and is more commonly associated with ganglioneuroblastoma or ganglioneuroma. It causes severe intractable diarrhea resulting in hypovolemia and hypokalemia. So, other syndromes associated are William-Pepper or Pepper syndrome. That is, there will be the localized primary tumor, but the metastasis is limited only to the skin, liver, and bone marrow in age children less than 1 year. It is called Pepper syndrome. It is associated with stage 4S neuroblastoma. Stage 4 is neuroblastoma is one of the important entrance question. That is, it includes age less than 1 year with metastatic disease limited to skin, liver, and bone marrow. Some of the cases of 4S will have spontaneous regression. In rare cases, it may result in massive hepatomegaly, respiratory failure, and overwhelming sepsis. So, in case of 4S neuroblastoma, it is necessary to closely follow up the child, where in most cases there will be a spontaneous regression. But in some cases, there will be the massive hepatomegaly, respiratory failure, and overwhelming sepsis. Another associated symptoms are Hutchin syndrome and blueberry muffin nodules. In babies with neuroblastoma, there will be the blueberry muffin nodules, that is, the metastasis into the subcutaneous tissue to form the nodules. When provoked, these nodules become intensely red and subsequently black for several minutes. So, it is due to secondary release of vasoactive metabolic tumor byproducts. Hutchinson syndrome is due to the metastatic deposits into the bones, relating to the pathological factors resulting in the bone pain. This metastatic deposits can be in the retroorbital region, resulting in the periorbital swelling and proptosis. Then what is opsoclonus myoclonus syndrome? It is specific for the neuroblastoma when there is a rapid conjugate ion nystagmus in the involuntary spasm of the limbs. Although it is rare, it occurs when these antibodies cross-react with the cerebellar tissue. It is not due to the metastatic deposits. It is due to the antibodies which cross-reacts with that of the cerebellar tissue, resulting in opsoclonus myoclonus syndrome. So the syndromes associated with neuroblastoma are Kernes-Morrison syndrome due to vasoactive intestinal polypeptide resulting in secretory diarrhea, Pepper syndrome due to metastasis of the to skin, liver, and bone marrow in less than age only. It is associated with 4S. Blueberry muffin nodules due to metastasis of subcutaneous tissue. In metastasis to bone, it results in severe pathological fracture and bone pain, resulting in Hutchinson syndrome. When there is deposits in the retroorbital region, resulting in raccoon eyes. When the antibodies cross-react with that of the cerebellar tissue, resulting in opsoclonus myoclonus syndrome. So, there is the raccoon eyes and the proptosis of the eyeball, resulting in the retroorbital deposition of the metastatic deposit. Investigations commonly done are abdominal X-ray. In case of lymphoma, there will be no calcifications, but in case of neuroblastoma, there will be the calcifications. The chest X-ray to note metastasis, abdominal ultrasound and a thoracic or abdominal CT. When you suspect the extension of tumor into the spinal, then MRI should be done. And neuroblastoma is frequently metastasis to the bone, so the skeletal survey of the cortical bone should be done necessarily. And what is the use of MIBG scan? What is MIBG? Meta-iodobenzyl guanidine. It's a labile isotope derivative of the norepinephrine. So, and it is quite sensitive and specific in detection of metastasis to the bones and soft tissues. So, it is the isotope of norepinephrine. So, in case of neuroblastoma, metastasis to the bone and soft tissues, it is more specific. And it is also recommended for the reassessment both during and after the treatment of neuroblastoma. PET scan or phosphoramidite tomography be used for, in some cases, there will be the non-MIBG aware disease. In that cases, PET scan to be done for follow-up of the high-risk cases. In 90% of the neuroblastomas, there will be the elevated levels of catecholamines and their metabolites, including HbA and BMA, that is homoallylic acid and BMA. When there is a high proportion of homoallylic acid, then that of the BMA, then it is more of undifferentiated tumor. In case of differentiated tumors, the BMA levels will be more than HbA. So, it is the pathway, that is the HbA is early reformed and BMA is lateral formed. and there is the ratio of HPA to VMA is more, then the tumor is mostly undifferentiated. When the ratio of VMA to HPA is more, then it mostly of differentiated tumor. So another markers of elevation recurrence are LDH and ferritin levels. These are useful in diagnostic as well as the prognostic markers. More than 96% of the individuals with metastatic neuroblastoma will secrete neuron-specific endolysis. So neuron-specific endolysis levels should be detected. If it is elevated, it is associated with very poor prognosis, indicative of the metastasis. That is the CT scan showing calcification with irregular borders and the tumor crossing that of the midline. HPA shows that of the small blue round cell tumors are undifferentiated type. So, for the treatment of the tumors, it is necessary to stage the disease. To stage the disease, the following are the specific requirements for neuroblastoma. That is, bilateral bone marrow aspirate and biopsy to rule out bone metastasis, abdominal or chest CT scan, bone scan, MAPT scan. Whereas MRI is rarely indicated when you suspect the extension into the intraspinal regions. Okay. But specific requirements are bilateral bone marrow biopsy, bone scan, MAPT, and abdominal CT should be done in all cases with neuroblastoma. So, neuroblastoma classification staging system is INSS staging system. In INSS staging system, that is International Neuroblastoma Staging System. Stage 1 is localized tumor with gross excision. It is the post-surgical staging. It is important that both for Wilms tumor and neuroblastoma, it is a post-surgical staging. ANS is a post-surgical staging. One is the localized tumor with the complete gross excision with ipsilateral node negative. 2A is the localized tumor with the incomplete gross excision but negative for ipsilateral node. 2B is localized tumor with or without complete, but ipsilateral non-adherent lymph nodes is positive for tumor. So one is R1 or R0 but N0. 2A is R1 or R2 with N0. 2B is R1 or R2 with N1. Stage 3 is unresectable unilateral tumor with the contralateral regional lymph node involvement or the tumor crossing the midline with a bilateral extension. Stage 4 is metastasis. 4S in neuroblastoma, 4S is the specific type. That is the child with less than 1 year with metastasis to skin, liver, and bone marrow. So for preoperative staging system, the new risk assignment of neuroblastoma is done. That is the new INR-GSS staging system. In this, they account for age, tumor grade, NMIC amplification, unbalanced lymph node, and ploiding. Based on this, they classify this into low, intermediate, and high risk neuroblastoma. Stage 1, 2, and 4S with favorable biology comes under low risk group. Stage 3, 4, and 4H with low NMIC classification comes under intermediate type. Amplified NMIC or stage 2 and 3 with unfavorable biology comes under high risk. So after staging, the neuroblastoma are grouped under risk groups, low, intermediate, and high. The therapies are based upon the final classification of the risk groups. For low risk groups, only frequent observation is necessary without any chemo or radiotherapy, or simple surgery is alone is enough. For intermediate risk group, it is combined with surgery and chemotherapy. For high risk group, first initially intensive chemotherapy is given, followed by surgery. That is multimodal treatment. Initially, intense chemotherapy is given, followed by surgery, followed by radiotherapy. Then bone marrow transplantation or stem cell transplantation is then followed by isoretinoic acid and GM-CSF factors infusion. So neuroblastoma is the high-risk tumor with possibility of metastasis to the skin, liver, and bone. The child presentation will be the subgroup, and it is classified into 4 stages, with specific stage being the 4S, which is age less than 1 year, only metastasis into the skin, liver, and bone marrow. And treatment is based on the risk group stratification. When the endemic or unfavorable biology or stage 3 and 4 comes under high risk stage, or low risk, only surgery or observation is enough. For intermediate risk, surgery combined with chemotherapy should be done. For high risk, it is a multimodal treatment started with intense chemotherapy followed by surgery and radiotherapy, then stem cell transplantation and monoclonal antibody substitutions are done. Then comes the another common tumor in the pediatric age group is the Wilms tumor, or also called nephroblastoma. It is an embryonal renal neoplasm consisting of metanephric blastoma. It also associated with other syndromes, syndromic association, that is with Becker-Friedman syndrome, Lee-Fraumeni syndrome, Dennis-Diaz syndrome, and WHER syndrome. These are the syndromic association of the Wilms tumor. In Becker-Friedman syndrome, it comprises of macroglossia, macrosomia, midline abdominal defect, and neonatal hypoglycemia. Lee-Fraumeni syndrome is associated with P53 mutation, while Dennis-Diaz syndrome, it is the combination of gonadal dysgenesis, Wilms tumor, and nephropathy. VAJR syndrome is aniridia, Wilms tumor, hemihypertrophy, genitourinary malformation, and mental retardation. These 4 are the syndromic association. The clinical features is usually presenting symptoms are an abdominal swelling or mass, which is sincerely finding, and abdominal pain. In some cases, fever, nausea, and vomiting may occur, hypertension, or hematuria. These are the usual presenting symptoms. This is the mass. Investigations being the normal routine blood investigations and RFT, abdominal X-ray, abdominal ultrasound showing the origin of the lesion, CT scan to look for extension of the tumor, involvement of the adjacent structures, and to rule out the lung metastasis. Most commonly, Wilms tumor metastasis to the lung. And MRI should be done in case of bilateral Wilms tumor or when MRI. So this is the smooth uniform Wilms tumor arising from the upper pole of the kidney with lower pole crescent-like structures. This is the normal lower pole of the kidney arising from the upper pole of the kidney. It does not crosses the midline. So surgical management is the preferred type with complete excision of the involved kidney with the ureter up to the distal end up to the bladder with accompanying nodes. This is the picture representation where is the normal upper part of the kidney. Now the tumor is in the mid and the lower pole. So coming to the histology, favorable histology is the more common. What is favorable histology? It is the triphasic component or triphasic tumor in which blastomal, stromal, and epithelial, all 3 components are present. When all three components are present, it is of favorable histology. Unfavorable histology is defined by the presence of anaplasia, clear cell sarcoma, and rhabdoid tumor. Tumor staging is the most important criteria in the therapeutic and prognostic stage of the Wilms tumor. It is also a post-surgical stage, that is NWTS, National Wilms Tumor Study Grouping System. case of Wilms tumor, it is classified into 5 types. And stage 1 tumor is limited to the kidney and completely accessed without rupture, and the renal capsule is intact. Where the type 2, the tumor extends through the renal capsule, but it is completely excised without no microscopic residue. While stage 3 is the residual tumor confined to the abdomen and the non-hematogenous space. It includes a tumor's involvement with the abdominal lymph nodes, diffuse peritoneal contamination by the rupture, or any microscopic positive residual margins. Metastatic disease comes under type 4. The special type is the type 5, where there is a bilateral Wilms tumor, which is again classified according to the involvement into the stage 1 to 4. The stage 5 is the bilateral Wilms tumor. According to the stages and also according to the favorable histology or with the presence of anaplasia, clear cell tumor or rhabdoid, the treatment differs from surgery to various chemotherapy administration for 18 weeks and up to 24 weeks. It is mainly based on platinum based chemotherapy with the dactomycin, cyclophosphamide, carboplatin, and vincristine based chemotherapy. Treatment for stage 1, nephrectomy with 18 weeks of chemotherapy depending upon the age of the patient is required. If the child is less than 2 years of age and the tumor is less than 550 grams, there is no need for chemotherapy. So only nephrectomy is required and can be kept under observation. For stage 2, nephrectomy with abdominal radiation with the 24 weeks of chemotherapy should be given. For stage 3, abdominal radiation with 24 tumor and a nephrectomy should be done after tumor shrinkage. For stage 4 cases, nephrectomy, abdominal radiation with chemotherapy, and if there is a radiation to the metastatic site radiation should be done. Stage 5, individual therapy based on the tumor stage. The most common being the Wilms tumor, nephroblastoma, that is, and neuroblastoma. Then the another tumor in the childhood is hepatoblastoma. It is the most common primary liver tumor in children. It is more occurrent male with a ratio of 1.7:1. It usually affects children younger than 3 years. The median age of the diagnosis is 1 year. The right lobe is more commonly involved than the left in for hepatoblastoma, and the bilobar involvement is 20 to 30%. It accounts for 79% of the all liver tumors and almost 2/3 of the primary malignant liver tumor in pediatric age group. So, most common primary liver tumor is the hepatoblastoma. So, it's also associated with Beckwith-Vineman disease, familial adenomatous syndrome, hemihypertrophy, low birth weight, and loss of endocytosis. The associated factors included and predisposing to hepatoblastoma in maternal age, maternal smoking during pregnancy, maternal use of OCPs. It also associated with the TPN related cholestasis and type 1 collagen storage. Coming to the clinical features of hepatoblastoma, the most present presents with the abdominal mass. The less common symptoms are decreased appetite, anorexia, weight loss, and nausea. In some patients, it is associated with back pain, fever, and abdominal pain. Rarely, it presents with acute pain or abdominal pain due to rupture. So, the investigations for hepatoblastoma are CBC, LFT, electrolytes, urea creatinine, and AFP is the most important prognostic indicator. In confirmed case of hepatoblastoma, when the AFP is less than 100 microgram per annum, case of poor prognostic factor. Usually in hepatoblastoma, AFP is elevated. Child with hepatoblastoma, the AFP is less than 100 microgram per annum. This is a poor prognostic factor. Abdominal chest X-ray shows the right upper quadrant abdominal soft tissue tumor. In rare cases, calcification may be seen. Abdominal ultrasound is done to locate the site of the lesion on the lobe. Chest and abdominal CT scan is definitive. MRI is done in necessary cases. Well, in hepatoblastomas, technetium-99 sulfur chloride liver scintigraphy is usually performed. Usually, these hepatoblastomas can demonstrate hypervascularity with prominent traceability at the site of tumor within a few seconds. So, sulfur chloride liver scintigraphy is specific. So, it can be used to detect hepatoblastoma. In hepatoblastoma, there will be hypervascularity and traceability of the site of tumor within a few seconds. This is the hepatoblastoma involving both right lobe extending into the left lobe of the liver. So, staging of the hepatoblastoma is the pretext staging system depending upon the section of the liver involved. That is the segment, depending upon the segmental anatomy, it is divided into the pretext staging system. Only one section is involved. That is, when the three adjoining segments are free, they staged as stage 1. When one or two sections are involved with the two adjoining sections free, it is considered stage 2. Only one adjoining segment is tumor free, it is stage 3. When the 4 sections are involved, it is stage 4. So, for hepatoblastoma, it is the pre-treatment staging system, that is the pre-stage classified into 4 stages depending upon the involvement of the sections of the liver. So, after surgery, that is post-surgical staging system, it is staged into 4 stages. The hepatoblastoma that is completely removed, stage 1, mostly removed with small amount of the cancer left, that is stage 2, cannot be completely removed, but also found in lymph node involvement is the stage 3, metastatic is the stage 4. So, again, hepatoblastoma is classified based on the histology.
ज़्यादा भी चलेगा.
Based on the histology, the hepatoblastoma is classified into hepatoblastoma polyepithelial type. It is the most common, accounting for 50%, and a mixed epithelial and mixed lymphomatosis, accounting for 45%.
बहुत ही ज़्यादा पेन चल रहा है. बहुत ही ज़्यादा पेन चल रहा है मेरा कुछ दिन से.
तो कोई ऑइलमेंट नहीं क्या बाम समथिंग
है ना.
The treatment of the hepatoblastoma.
ये देखो ना, मेरे टेबल के ऊपर देखो वॉल्यूम स्प्रे. टेबल के ऊपर देखो वॉल्यूम ऊपर मिला.
The treatment of hepatoblastoma is complete surgical resection of the tumor at the time of diagnosis, followed by adjuvant chemotherapy. However, the prognosis remains poor in the children with residual tumor after initial surgical resection. So, what are the contraindications of the hepatoblastoma for the immediate resection? It include when the tumor is extensively in bilateral liver involvement, or when there is the presence of vascular invasion of major hepatic veins or inferior vena cava, or when there is a multifocal diffuse disease, or when there is distant metastasis. These are the contraindications for immediate resection. So, in these cases, we should start with preoperative neoadjuvant chemotherapy, and then eventually lead in liver transplantation. Then the last topic is the teratoma in children. The most common locations for teratoma are sacrococcygeal teratoma, that is the most common, 57%, and some commons are gonads, mediastinal, retroperitoneal, and rarely intracranial and cervical. Very rare sites include stomach, intracranial, and nerve. Most common location of teratoma in children is sacrococcygeal teratoma, accounts for 57%. Second most common being the gonads. So, Sacrococcygeal teratoma occurs more often in the girls than in the boys. Ratio is 3:1 to 4:1. It may be diagnosed antenatally during routine ultrasound. The most common presentation is the presence with a large, predominantly benign tumor rotating from the sacral area that is noted prenatally or at the time of delivery. Less commonly, this newborn may exhibit only asymmetry of the cortex are present when aged 1 month to 4 years with the pre-sacral mass that extends to the pelvis. Then later presents symptoms of bladder or bowel dysfunction. So this is a picture of the sacrococcygeal teratoma writing in the sacrococcygeal region. Among the sacrococcygeal teratoma, 50% will have associated congenital anomalies, such as imperforatinous sacral bone defects, spina bifida, myelomeningocele, and duplication of icterata edema. When there is an elevated serum alpha beta protein or beta histology, it will indicate malignancy. It is occur rarely. When the presentation is early and the surgical treatment is done before 1 month of age, the malignant degeneration is very less. As the age progresses, the malignant degeneration or the development of malignancy chances increases. So the investigations by ultrasound regarding the extension of the tumor to classify the type. The classification is based on the location of the tumor and its extension. It is called Altman's classification. So this is the MRI showing the pre-sacral mass, the sacrococcygeal teratoma completely in the intra-abdominal region. So Altman's classification, there are 4 types. Type 1 being the most common, that is 45%. It is most predominantly external, only attached to the coccyx and may have a small pre-sacral component. Type 2 is both external and significant pre-sacral pelvic extension. Type 3 is only just visible externally but predominant pelvic and intra-abdominal. Type 4 is externally clinically normal, no extrasacral involvement, totally, completely, entirely pre-sacral and intra-abdominal. So type 1 is predominantly extrasacral. Type 2 is with a little extension into the pelvic component. Type 3 is predominantly pre-sacral in the intra-abdominal region. Only small portion is visible externally. Type 4 is complete intra-abdominal and pre-sacral tumor. So treatment depends upon the type of the tumors. Complete excision should be done with the chevron-shaped buttock incision with careful attention to the preservation of the muscles. As the tumor is adherently attached to the coccyx, if the remnant of coccyx, the chance of malignancy and recurrence is more common. The coccyx should be resected with the tumor. As when and where the coccyx are not resected, there is chance of 40% recurrence. So hemorrhage from the medial sacral vessels and hypogastria is the most common complication and it should be taken care of. This is the massive type 1 sacrococcygeal teratoma. So it is excised using chevron-shaped incision with removing that of the coccyx and preserving the musculature. This present as the intrapelvic mass with compression of the bladder. Bladder is catheterized and it is the complete intra-abdominal perisacral mass which is excised. So this is the end of the session. Thank you, one and all. If you have any doubts, you can ask. So, general pediatric surgery with CDH and congenital lesions and TA for discussion first session and neonatal obstruction in the second session. and biliary atresia, choledochosis, and tumors of the pediatrics have been shared in the third session. So if you have any doubts, you can ask, please. Does anyone have any doubts, or can we end the session? Hello, am I audible?